सर्वांगी सुंदर शेंदुराची कंठी साजे माळुता फळाची जय देव 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 जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव 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 जय देव.
Thank you, Revati, for the wonderful performance. Infertility hurts, but it doesn't stop us from trying. As long as there is tiniest, wildest chance, we can't give up. Oasis is a spot of refreshing water in the dry and barren desert land, quenching our thirst and giving us strength and hope. Similarly, we at Oasis Fertility aspire and work hard towards giving the joy of parenthood to all the couples facing these troubles, helping them medically, emotionally, financially, and with compassion to fulfill their dream. Oasis Fertility, a unit of Sadhguru Healthcare, was founded in November 2009 by Dr. Durga Rao and Mr. Kiran Gadila. Leadership is the capacity to translate vision into reality. Our CEO, Mr. Sudhakar Zadav, has been with Oasis Fertility since 4 years. He has helped Oasis operations grow substantially over the years, taking it from 8 branches to over 25 branches nationwide, with many more summits to come. I request Mr. Sudhakar to give us an insight on the successful journey of Oasis Fertility.
Thank you, Apurva. Very kind of you to talk about me. But anyway, let's get started. A very warm welcome to all of you. We are very excited to be in Pune. In fact, this is the occasion which we have been longing for almost close to 1.5 years, and COVID came in between. So, nevertheless, I think today we are here. A great start at Pune. So what I'll do next 5 to 7 minutes is that I'll take you through our Oasis journey in terms of where we began and where we are today in next few minutes. Well, I think as Apurva said, we started our journey under leadership of Dr. Durga Ji Rao. She started the company Oasis Fertility way back in 2009 along with Dr. Mr. Kiran Gadela. We are an ICMR registered and ISO 2001 certified organization. Just to bring you on records here, out of 3,500 fertility centers which are operating today in country, only about 550 or 600 are ICMR approved. And I think our next step towards quality accreditation is the entire ART bill, which we are going to embrace very soon. Well, we are ranked number 1 in South India, number 3 all over India. This was ranking given by the Times of India, and we have been the most trusted experts in fertility treatment. These are our co-founders picks of Dr. Durga and Mr. Kiran. This is our core medical team. We have Dr. Krishna Chaitanya also going to speak today, along with Dr. Nilesh. Of course, I'll speak more about Dr. Nilesh in my coming slides. Right? Incredible journey of 25 centers across the country. We are currently in Telangana, AP, Maharashtra, Karnataka, Tamil Nadu, Gujarat, Jharkhand, and Odisha. Pune was always dear for us, and then I think last 2 years back we started very quickly. We ramped up the operations. We started second center at Kharadi, and this all under leadership of Dr. Nilesh, who's with us here today. In fact, it's not going to stop us. We are aiming at about 50 centers in next couple of years. Well, I think what drives us is the entire acknowledgement which is given by the industry. Very recently, we have been awarded as the Growth Champion for year 2022 by Economic Times, and array of awards which you can see on the slide. I think our core fundamentally is our patient-centric approach. I think for us, the most important person on the floor is the customer who actually comes to our centers across the country. We have been extremely patient-centric, and for us, the service excellence has been one of our strategy in terms of growth. Talking about our ethos, we are not really in a rat race of becoming a number one or a number two. For us, I think it's being most respected player in the IVF space is something which we would aim for. And I think, I've been hearing Dr. Durga always saying that we as an, IVF enterprise, we always try very hard to give a biological child to the coming patients who come to the centers. Right. So I'm sure the clinical part will be dealt by our clinicians today in the afternoon. Well, these are our core values in terms of our, which we call it as 5C, being compassionate, being competent, giving customized treatments to the patients, maintaining extreme confidentiality, and being very, very careful when we do our treatments. Hence, patients can, there's no mix up of gametes there in the IVF lab, right? But one particular aspect which I would like to highlight is that for us, credibility scores over commerce. Right? For us, I think credibility is the most important. We know that once you do the hard work, the success actually follows you. We have been leading the IVF space. This is a snapshot of the work which we have been doing in the last 10 years. 50,000 happy families which we have built over a period of time. We do more than 15,000 IVF cycles annually and about 20,000 IUI cycles annually. And talking about our clinical experience, we have got more than 300 years of experience collaboratively. And success rates are well above the benchmark when compared to global standards. We are a strong 600 plus employees. In none of the centers we do batching. Every center has a dedicated embryology team under the leadership of Dr. Krishna, and it's all supported by a very, very strong corporate team which operates out of Hyderabad. Adhering to the highest quality standards, most of our centers are NABH certified organization. We have very recently embarked on QI journey, and then very soon all of our centers would be a QI accredited centers, and we are member of ASRM and FOXY. Talking about our labs, all our labs, absolutely no compromise when it comes to the quality. Each of our labs, we maintain class 10,000 environment. All our consumables are MEA tested for toxicity, and we maintain HEPA filters in every lab and every theater which we operate, and all of our labs and theaters are state of the art, right? Of course, wide spectrum of treatments, would not like to dwell more upon here. Success rates, I'm sure this will be covered with our clinical team. One particular point which I would like to focus that being in fertility space, we just do fertility. We don't do ops and gynae at all. Rest assured that once the patient comes from your clinic to our centers, we send the patient back to your clinic, and then we have a wonderful system called Artis where every referring doctor can actually access the treatment journey of the patients. So we ensure that the feedback is continuously given to the patient till the patient actually reaches back to the referral doctor. Talking more about Artis, this is our backbone for the entire clinical data and non-clinical data which we feed. Right from the first phone call of the customer till the childbirth, the entire journey of the patient is tracked in Artis. So that's the competency of Artis which we follow in each one of our centers. This is purely a home-based in terms of indigenous built Artis, and this is done entirely by our tech team within in-house. Well, you'll agree with me. I think Dr. Krishna will speak more about our AndroLife clinics. Each one of our centers actually run AndroLife clinics. So what is AndroLife clinic? Today, fertility is just not about female prerogative, but I think it's 50% equally contributed by male as well, right? So that's where we started a dedicated andrology clinic where we treat male fertility. And the reason being, I think most of the times we felt that male is always in a denial, and then we always wanted to have this exclusive male fertility clinic, which we have started and have been running successfully in each one of our centers. Ask Oasis is again a very new initiative. It's like Google in fertility space. You can go. I mean, it's basically for laymen and for general public. If you have any queries about fertility, people can go here and then ask their questions, and Ask Oasis would actually answer them back. Well, I think this was the innovation which we did during our COVID times. We started this initiative called IVF at home. Not everything can be done at home, but I think 60% of the job still can be done at home in terms of giving the injections and investigations at home. Rest of the things can be done at the center. Amulya is one of our CSR. We always believe that we should be giving back to the society. This is something which I wanted to talk about here. Every center is dedicated and committed to do a free IVF for poor and needy patients. Would request you to reach out to our Dr. Nilesh in case if you have any poor or needy patients who are genuinely need of help. We are happy to help them free of cost. So that is Amulya for us. I want to be a millennial mom. This is something which is very, very dear to Pune Center, and this is brainchild of Dr. Nilesh. He has been successfully running this program for last 2 years in Pune. Well, this is my last slide. We are talking here about our academics, which is very, very close to Dr. Durga ma'am's heart and Dr. Krishna's heart. I think we have dedicated a lot of time in building up excellent program called Oshram. This is a dedicated wing, academic wing of Oasis Fertility, where we train people. If anybody is interested, please, you can reach out to any one of our colleagues here. So we provide FRM courses at various centers across the country. Also, we have got 2 DNBCs every year, and then we run number of embryology courses also, both in short term and long term. These are our speakers along with our dignitaries who are going to speak today. With this, I would request Apurva to take on. Thank you so much.
Thank you, sir. I request our eminent dignitaries to come to the dais for lamp lighting. Dr. Durga Rao, co-founder and medical director, Oasis Fertility. Dr. Krishna Chaitanya, scientific head and clinical embryologist, Oasis Fertility. Dr. Sonal Panchal, consultant radiologist at Dr. Nagovi's Institute for Infertility and IVF, Ahmedabad. I request Dr. Nilesh Palkavde to escort our chief guest, Dr. Parag Binewale, President POGS, to the dais. Our guest of honor, Dr. Hemant Deshpande, couldn't be here due to unavoidable circumstances.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदम् शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्थं ज्योतिषा प्रभुरव्ययः ओ दीपब्रह्मरूपस्थं ज्योतिषा प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति तदेन्द्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदम्
I request the dignitaries to please stay on the dais. I request Dr. Nilesh to welcome the dignitaries. I request Dr. Kanchan to please welcome Dr. Nilesh. Thank you. Integrity, insight, and inclusiveness are the three essential qualities of leadership. One such leader, Dr. Nilesh Balkavde, clinical head and fertility specialist, Oasis Fertility Pune, offers a decade-long distinctive experience and expertise in the fields of infertility, reproductive medicine, and gynec endoscopy. He brings his professional expertise in various aspects of reproductive medicine to the Oasis family, which includes optimizing success of IUI-ICSI cases, managing recurrent IVF failures and pregnancy loss cases, managing fibroids and endometriosis endoscopically, along with high-risk management and obstetrics. Under his leadership, Oasis Fertility Pune recently celebrated the successful completion of 2 years at Wakad and 1 year at Kharadi Center. I request Dr. Nilesh to speak a few words about today's conference.
A very good, a very good afternoon to all of you delegates. Respected Chief Guest, Dr. Parag Beniwale sir, my mentor. Sonal Panchal madam, again my mentor. I have learned ultrasound in fertility with her. And our medical director, Dr. Durga Rao, and scientific head, Dr. Krishna Chaitanya. At the outset, I would like to say, Mahajano yena gataha sa sanmargaha. So just follow the path of people who have proven themselves. So that's what I'm trying to do. What Durga Madam has done in South and what Parag sir has done in Pune and in his academic journey, just trying to fulfill, just trying to follow the paths and the footsteps of them. However, we all know that we cannot reach up to that mark, but we can always try and have these people as our mentors. Oasis Fertility Pune has been an amazing journey for the last 2 years, and we started the journey right when COVID started. So I just began my OPD in March 2020 when the first case of COVID was diagnosed in Hyderabad, and I had to cancel my ESAR flights then. And that's how the journey started. And to set up and start a fertility journey with so few number of patients and to strive hard and to come to this level where Oasis Fertility Pune is right now is being an amazing journey. And of course, it comes with hard work and with support from all the corporate team, then clinical team from Hyderabad, the team here in Pune has been really an amazing journey. We are able to give success rates which are at par and above that in the international plethora, whatever success rates are there, we are definitely giving more success rates with the more recent advanced techniques which we have, which already have been elaborated previously. I feel patient-centric approach and the empathy towards patients is what matters to me as a person. The ethics and transparency of practice makes you a lambi race ka ghoda than just falling for few things like a very high success rate, maybe a very cheap IVF. All these like will fall apart. What will be with you is your uh, courage to fight, your hard work, your ethics and transparency, and that's what we have been doing at Oasis Fertility Pune. With this, I feel the academics shouldn't be on a lower part, and that's why we have our academic wing by Ashram. We have two of our fellows who have completed long courses of fellowship of reproductive medicine at Oasis Fertility Pune. Of course, many of the fellows have come up in recent years at Oasis Fertility Hyderabad as well through this Ashram wing. With this ashram, we are also organizing hands-on workshops at Pune centers regularly, may it be semen washing, may it be hysteroscopy, and short and long courses in infertility. I feel as again a next page in this was the ART conclave, which was long due and was not held because of COVID. And I thank all of you for such a wonderful and generous response. We had wonderful workshops in the morning where we were having a didactic interaction with you along with a hands-on workshops in 3 different modules. I congratulate all of you who have worked on these workshops and hope you receive the certificates. I thank at the outset at this moment. I would like to thank Team Oasis for organizing this event, the corporate team, Dr. Durga Rao Madam, Dr. Krishna Chaitanya for this event. I would like to thank President POGS, Secretary POGS, and all team of Pune Gynec Society, the office bearers of Pune Gynec Society, for giving their wholehearted support for this conference, because this is a ART conclave in association with the Pune Gynec Society. I would also like to thank our academic partners, our sponsors, and also like to thank the event team by Variant Vikram. I hope you have a wonderful academic experience further also. I would request, as I'm a chairperson of Foxy Quiz Committee, I request you to download Kahoot apps in your mobiles, because we are going to have a quiz session also. It's going to be fun along with the learning experience. So thank you, all of you. Thank you.
Thank you, sir. Genius is 1% inspiration, 99% perspiration. Our co-founder and medical director, Dr. Durga Rao, is also present here today. She is a specialist in reproductive medicine and minimally invasive surgery. She is responsible for bringing in the most advanced ERT treatments at OSS. With her experience, competence, and personalized approach towards every patient, she is now one of the leading voices in fertility industry. Productivity is the result of commitment to excellence, intelligent planning, and focused effort. Also present with us today, our scientific head and clinical embryologist, Dr. Krishna Chaitanya, is an expert in clinical embryology and cryopreservation of gametes and embryos. With over 10 years of experience, his main areas of work at OSS are cryobiology, in vitro maturation of oocytes, embryonic stem cells, andrology, and men's health. On today's occasion, we would like to take this opportunity to launch our souvenir, Art of ART, today by the hands of our esteemed guests.
I would like to state here that please don't forget to collect your copy of this souvenir, because this is a take-home message for everybody. Whatever happens this ART conclave, I thank all the editors, including Dr. Durga Rao Madam, and all the contributors for this. This is a very easy take-home message in the form of algorithms for all of you in difficult case scenarios in infertility. Thank you.
Thank you, sir. Our guest of honor, Dr. Hemant Deshpande, couldn't be here due to some unavoidable circumstances. A doctor's devotion and care brings healing, comfort, and hope. Our chief guest, Dr. Parag Biliwale, President of Pune Obstetric and Gynecological Society, Pune, has an experience of more than 23 years in the field and practices at his own clinic, Biliwale Clinic. I request Dr. Parag to speak a few words.
Good afternoon. I bring greetings from the Pune OBGY Society. And I must compliment and thank Dr. Durga, Dr. Krishna Chaitanya, and of course our dear friend Dr. Nilesh for partnering with Pune OBGY Society and having me here. I'm not an infertility specialist. Nilesh is our man to go wherever we have any doubts. So I'm sure it's going to be a great learning experience when you have speakers like Dr. Sonal, who's one of the best we can have in our country. I think it is going to be an excellent experience for all the delegates. Infertility, I'm not going to talk about it, but it's a challenge. And for us, it's easy because we then ask Nilesh to look after our patients, and we do our bit when they become pregnant. I had an opportunity to visit the Oasis Center during the COVID times, and it is definitely worth a visit. So those of you who have not visited Oasis must visit that place. And this was when Nilesh was elected as the chairperson of quiz committee, so I took an opportunity to be there. And Durga, I must compliment your team because the kind of care that is received by our patients is amazing. It is not only management of the medical condition, but it is also taking care of their mental health. And I think your team is doing a fabulous job in this. So I'm not going to take much of your time. My best wishes for the program and happy learning to all of you. Thank you.
Thank you, sir. Thank you to all the dignitaries. I request all of you to settle in the audience as we will shortly begin the academic event. Before we go, I request Dr. Nilesh Balkaude to felicitate our chief guest. Hello. Good afternoon, everybody. I'm Dr. Rashmi Nifadkar. On behalf of Team OSS, it gives me great pleasure to welcome all of you for this ERT conclave. Without further ado, let's jump into our scientific sessions. For our first session, I would like to welcome on stage our two chairpersons, Dr. Vaishali Chavan and Dr. Rajeshwari Pawar. Dr. Vaishali Chavan is the Director of Obstetrics and Gynecology, Sahyadri Super Speciality Hospitals, Hadapsar, Pune. She also practices at Sanvi Clinic. She's been a chairperson, Perinatology Committee, FOXY 2018-2020. Welcome, ma'am. Our second chairperson, Dr. Rajeshwari Pawar, is a consultant obstetrician and fetal medicine expert. She has a graduate diploma in prenatal genetics and fetal medicine from UCLH. Welcome, ma'am. Our first speaker is none other than Dr. Durga Rao. I request Dr. Vaishali Chavan to please introduce our speaker.
Thank you for the kind introduction. It's indeed a great privilege to be here. Huge, big congratulations to Dr. Nilesh Balkaude. As we know, he's an extremely dynamic young chairperson, Foxy, and he's taken the country by storm with his innumerable activities. And in the same way, with OSS, he has taken the fertility scene in Pune by storm with his dedication, hard work, devotion, and of course his brilliance. And it is indeed a pleasure to give an introduction of none other than Dr. Durga Rao, who is a legend in the field of infertility. And she is co-founder and medical director at OSS Fertility, a specialist in reproductive medicine and minimal invasive surgery since past 26 years. And she has been a pioneer in research and practice of in vitro maturation treatment. She's practiced in UK and Canada, and I was listening to the speeches, Dr. Durga, and it is truly inspiring to hear about your amazing journey over past so many years and more than 25 centers that you have established and doing such good work. Well,
Thank you very much, Chairperson. But I think the credit goes to the team that which includes Dr. Nilesh. And I think youngsters who have got so much passion and interest in the field is what is actually taking OSS. So I'm actually at the backbench. It's these people who are leading it, and I'm very proud to say the kind of team that we have managed to build is amazing.
Thank you so much for the words, though. Thank you. So, Dr. Nilesh actually wanted me to discuss about unexplained infertility. And the reason I think, or the thought behind this was because in some of the discussions that we are having over the rest of the evening, the male counterpart is being discussed, and so are the women and the different problems that they come with. But one aspect which I think confounds everybody is, we look at all the reports of all the both the couples, and we all end up saying everything looks fine, and that is so frustrating even to the couple in front of us. They say, "You tell us that everything is fine, but we're still not conceiving." So, there are quite a few things that we need to understand so that we can explain to the couple that though it is unexplained, that doesn't mean there is no problem. Unexplained is because, as far as science is concerned and as far as our investigative capability is concerned, we have looked at all the parameters and we say we can't find an answer. That doesn't mean there is no problem. So let's look deeper into this aspect and see how best we can answer their questions. But first comes the definition. And I think when I'm really looking at all the articles that are being published, all the meta-analysis and everything that is being published, there are so many varying definitions to this. And that is the reason why we still haven't come back to actually say which is the best treatment for unexplained. But what does the definition actually entail? It is three broad categories, and that is the woman should have at least one patent fallopian tube. The second thing is documentation of ovulation. Just because a woman comes back and says that I have regular periods does not mean that she is ovulating. And in fact, recent data suggests that at least 25% of women who say that they have regular periods may not be ovulating every cycle. So documentation of ovulation either in a mid-luteal progesterone or a follicular, which I'm sure Dr. Sonal Vancha will be talking about, in terms of the development of a follicle and a rupture of a follicle is what needs to be documented. And the third most important thing is a semen analysis. And when we are talking about unexplained infertility, the important factor that we have to look at in terms of a semen analysis is the motility. What is the total motile count in that semen analysis, in that semen sample that has been given to you is what determines whether it's unexplained or not. But if you noticed, there are some categories and there are some aspects which are actually not being introduced or spoken about in the definition. One is there is absolutely no inclusion of ovarian reserve. We know that fertility, when we are talking about a woman's fertility potential, the most important aspect is age and her ovarian reserve. In that order, age, ovarian reserve. And the definition that we are speaking about in terms of unexplained does not take these two into consideration when we are talking about a management. The third most important aspect is duration of infertility. You might have a 28-year-old. One 28-year-old has been married only for 2 years, and one 28-year-old has been married for 7 years. There's definitely a difference, even though they are both the same age. So we have to take all of this into consideration when we are going to chart a management protocol for this couple. Now, when we are talking about ovarian reserve, and this is something as specialists that we need to know so that we can educate the couple, is as age increases, there is a depression in your AMH. You might find two different AMH reports, one in 2020 which says 1.2 and one in 2022 which says 1.8. Is it got better? No. AMH never gets better. It is only the variations in the lab and the way it is being assessed that is giving you two different reports. But as you can see from this graph, as a woman ages, right from 25, the AMH is coming down. And this figure is pretty alarming, which says that after 25, at least 6% decrease in AMH occurs with every year. So see how age is important in terms of fertility. Now, how in giving you in a broader perspective, if you're looking at a cumulative pregnancy rate, and I'm not talking about just 1 month's pregnancy rate, I'm talking about a cumulative pregnancy rate over 2 years, could be as high as 72% in a young woman who's less than 35. But once she crosses 35, it actually comes down from 70% to only 45%. And this last statement is extremely important. There's a decline to 30% for women with more than 5 years of infertility. So age as well as the duration of infertility is what is important for you to take into consideration. Now, if you notice also in the definition, we've said that patent tubes, ovulation, sperm. We said nothing about laparoscopy. We said nothing about diagnosis with laparoscopy. So according to the ASRM, doing a laparoscopy is not mandatory to call a couple unexplained. If you are doing a laparoscopy for any other reason, then yes, you might diagnose something, and if you still haven't diagnosed, then still remain in the unexplained. But what normally tends to happen is once you've done laparoscopy, usually, invariably, we do find certain pathologies which might shift them from unexplained to a particular problem. Now, coming to the management, now, since we have understand so many factors need to come into the picture when we're talking about management, what you have to understand, and this is why I said ovulation documentation is important, is because we are looking at ovarian stimulation and not ovulation induction. They're completely two different aspects. Ovulation induction is somebody who's not ovulatory, who's anovulatory, and you have to give medications for them to ovulate so that they either get pregnant or they have a period in time. Now, somebody who's already supposed to have ovulation, we should not be doing ovulation induction. She's already ovulating. What you're doing is to enhance that process of your ovulation for that woman by actually doing ovarian stimulation, which means that we are going beyond, we are accelerating the process of the mechanism in her so that we are producing more than one follicle. So, what are the options we have when we are coming about unexplained infertility? The first thing is expected management, which means that if a couple comes to you within a short period of duration of infertility, or if everything looks normal, you can still give them the option of expected management. And we'll talk about which group that is. Then we are talking about stimulation with timed intercourse, natural cycle IUI, ovarian stimulation with IUI, and IVF. Now, these 5 parameters are there, but not all of them are actually recommended. So let's see which ones are. When we are talking about timed intercourse with oral ovulogens like Clomid or Letrozole, it is very, very clear that it does not improve or it doesn't increase your chances beyond expectant management. Which means that rather than giving them medicines, pushing them towards a longer duration of infertility or being called as infertile couple, you give them these medications. Rather than doing that, you think if it's possible, you let them do expectant management. What is expectant management? What are we talking about here? Here, the first we have to discuss about the male, because this is one aspect which we fail to actually address when a couple sits in front of us. We look at the sperm analysis, we say fine, and he's out of the picture already. That shouldn't be the case. We have to educate them about the quality of the sperm that we require for a pregnancy to happen. And that doesn't depend just on those 3 parameters of count, motility, or morphology. We have to educate them about the prolonged sitting or sleeping postures which can affect it, tight undergarments, saunas, hot tub use, most importantly, extended periods of driving. And most of these IT people who keep the laptops in the lap and work continuously, and particularly now with work from home, the concept of desk and chair and away is already gone. So this is where our education to the man of the person responsible has to be taken into account. When we are looking at the women, we also have to understand the impact these common things have. One is obesity. If you can see, it actually increases your time to conception by 2-fold. What's also harmful is being underweight. With sometimes in some of our periphery clinics, we tend to see a lot of women who are coming from rural background actually not having the right nutritional support. And if you're underweight, in fact, your time to conception is 4-fold, which in fact is worse than obesity. Smoking, we all know, increases infertility by 60%. Alcohol, we are not talking about just 1 or 2 units per week. We are talking about much more than that. Definitely binge, which is not recommended, it increases your infertility again by 60%. Caffeine. When a woman is trying to conceive or is pregnant, 1 cup of coffee is what can be allowed. Anything beyond that, we have noticed that it does decrease your fecundability. Obviously, drug usage, toxics, and solvents also have an implication in terms of infertility. But when we are talking, about lifestyle changes, you tell a woman who's got a BMI of 35, you need to come down to 25, 27, which is what our Indian standards say. Is it possible? Definitely not. She's just going to find a neighbor and go get some prescription from somewhere, swallow it, and do what she wants to. The point that we have to understand before we even educate it is, we are not looking for a drastic change from a BMI of 35 to down to about 27. What we are really looking at is changing the imbalance. And that imbalance that is there in the hormonal profile actually gets better even if she loses 5 to 10% of her body weight. That little change is important to at least start the cascade of events. And there's so much of actually a jubilation and a kind of achievement that a woman feels that when you're encouraging her, yes, done, you've lost 2 kgs, very good, let's look at further. I think that encouragement and having the right kind of support from your nutritionist or your a nutrition wellness team is extremely important, and this has to be a backbone. It is not telling them you lose weight and come back to me. Some support has to be given to them. And this amount of even 10% weight loss, the kind of changes it brings about in your hormonal parameters, makes a great deal in terms of management. So here, when I said we are not looking at ovulation induction, we are looking at ovarian stimulation. What is the reason? The reason is because she's already ovulate, she's already producing one egg, she's having intercourse, but she still hasn't conceived. So if you're going to give her medication and she's still going to produce that one follicle, how are we actually improving her chances? So that's the reason why ovarian stimulation. But here, this is an extremely tightrope walk because you do not want more than 3. You want more than 1. You don't want more than 3. So your protocol has to be managed in such a way that you're increasing the number of oocytes, thereby also correcting any subtle ovulatory dysfunction that could have happened even though she was ovulating that one egg. And also because of all the hormones that are being given or being released by the growing follicle or the corpus luteum in the luteal phase, it's improving the chances of implantation as well. Now, why are we harping so much about stimulation and ovulation, ovarian stimulation? Is because this particular research article has made it extremely clear that if a woman is ovulating by herself, you haven't increased her number of follicles, but you're just doing an IUI in a natural cycle, again, you're not increasing her chances. So we found 3 different ways that we are not increasing her chances in unexplained. By giving her only Clomid and asking her to have intercourse, giving her only Letrose and asking her to have intercourse, or don't give her anything but you're doing IUI in a natural cycle. These 3 parameters or these 3 management plans really do not work. So what works? Ovarian stimulation with IUI works. And as we can see, it is better than ovarian stimulation only, which means that ovarian stimulation with TI or only a natural cycle IUI doesn't work. What works is ovarian stimulation with IUI. So here, when we are really looking at the different things that we can do, if you're giving Clomid with IUI, 3 cycles, you're achieving at least a cumulative pregnancy rate of 30%, whereas with expectant management, it's 9%. Now, this 9%, remember, this is only if an unexplained couple has been trying for at least 2 years. Because in the first 2 years, at least 70 to 75% of your women will conceive. So this figure is only for those people who have completed their 2 years of trying, regular intercourse, regular penetrative intercourse with regular periods, with a good sperm analysis, they still haven't conceived, their chances falls down to 10%. Now, if you're looking at Clomid with IUI, it's similar to giving Letrose with IUI. But the best and the best, brightest kid in the block is gonadotropins, which gives you almost a 32% versus a Clomid IUI, which is 9.4%. Gonadotropins, why is that the go-to thing? It's because it's very efficient. Your ovulation rate is almost close to 100%. Your conception rate is at least 30% per ovulatory cycles. But there is something that is still a hurdle for us to look at gonadotropins. What is it? Well, multiple pregnancies. Ultimately, when we are talking to a fertility specialist, when is it considered a success for us? A success is not seeing 2 lines on a strip. A success is not just seeing a heartbeat at your nuchal translucency scan. A success is when a woman goes home healthy. First point, the mother has to be healthy and she carries one single child going home without spending time and money in a neonatal care. So what we are really looking for is a singleton pregnancy. So multiple pregnancy is something that we have to avoid. In the beginning of journey of infertility practice, we used to put back 4 embryos, 5 embryos, whatever we created, everything used to be put back. But now we are slowly moving towards single embryo transfer because now we have realized that most of the problems or the reason why neonatology became so popular was because of us. You give multiple pregnancies, they have to be in neonatal care. So the limitation of a gonadotropin cycle is multiple pregnancy, wherein twins is 25%, and that's not less. High order, thankfully, is only at 5%. The second problem is OHSS, and obviously requires regular monitoring and is expensive. Now, if you look at all of these complications, at least the first two, it's iatrogenic. We are causing the problems. So the problem is not the woman, the problem is not the drugs, the problem is who's giving the drug, because we don't know how to give the drug properly. Now, another aspect of increasing pregnancies with, in at least in unexplained, is tubal flushing. Earlier, when HSGs used to be done with oil contrast, they found that as soon as HSG was done, quite a lot of people actually conceived by themselves because of the oil contrast, which was having an immunogenic potential of increasing your chances of fertilization. Now, then slowly came the studies of actually injecting lidocaine and doing a flush of the tubes. And one study, not many studies are there in this, but a few studies have shown that even that improves your chances of fertilization and pregnancies. Now, like I said, the problem is not the drug, but who is giving the drug. So what we have to be careful about and how you monitor your ovulation in stimulation protocol is such that you do not cross 3. Because as the number of follicles increases, so does your chances of pregnancy, which is good. But you go overboard, you're causing more harm than good. And the stimulation protocols, as we said, as you're looking at with oral medications, if you're going towards gonadotropins, either oral plus gonadotropins or only gonadotropins, your cycle chances are increasing. Now, there's always a standard question. When do we do IUI? Do we do IUI straight away at 36 hours without looking for ovulation? Or should we look for ovulation and only then do IUI? Well, lots of these questions have been answered repeatedly, and they said that your chances of pregnancy are same whether you do it at 24 hours or you do it at 36 hours. Again, documentation of ovulation has not been mentioned in most of the studies. That is something that gives us confidence that you've given the medication, she's not ending up in a luteinized unruptured follicle, so you want to ensure that she's ovulated, but the chances of pregnancy has not improved because of that one particular process. Now, the next question is the number of IUI, and I think this particular slide, which is a very recent study which was done in 21, has told us very clearly that your chances of pregnancy do increase substantially after the third cycle. But after the third cycle, it tends to plateau. Cumulatively, if you're really looking at the pregnancy rate, it is good, but after the third or fourth cycle, you're plateauing. Now, there was this FAST trial which also answered quite a few of our problems. That is, what do you do when a woman is young? How do we get her pregnant? And somebody with unexplained infertility. So this question was answered by this trial, which was called the FAST trial. And what they did was they gave 2 groups. One group took Clomid and did IUI. They didn't conceive, they went straight for gonadotropin, did 3 more cycles. And after 6 months, if they still haven't conceived, then they went for IVF. And the second group, what they did was Clomid, IUI was done 3 cycles, didn't conceive, went straight for IVF. So the second one was the fast track. And when they looked at both of these different groups, what they found was that, in fact, even though IVF was given after 3 cycles of Clomid itself, the time to pregnancy was definitely shorter. Not only that, what is also important is the cost is also cheaper. Why are we actually doing IUI? Because we want this woman to go home with probably less invasive, less intensive, and cheaper option. That's the whole point of IUI. But IUI is not as effective as IVF. But we're still considering IUI for the reason that it is obviously not increasing your cost, less invasive. The woman at least feels there's a natural way of conceiving. She doesn't feel my baby was born in a lab. So there are so many emotional factors also that contribute towards a pregnancy towards IVF, but towards IUI rather. So when they looked at these 2 combinations, they still found that if for 3 cycles, if you have managed to actually make them produce 2 to 3 follicles, remember, it's not just about making 1 follicle and saying, okay, I've tried 3 cycles, let's go for IVF. Your protocols also have to be managed that way. What about somebody who's crossed 37? Now that was for the younger group. What about the group who has crossed 37? What is the chance with them? What they looked here is this. If you looked at Clomid IUI, gonadotropin IUI or IVF, IVF was way better. And in this group, you have to remember that their ovarian reserve is coming down. Even if you have a 38-year-old woman and you're calling her unexplained, you can't put her through the whole journey of 6 cycles of IUI. This doesn't work. Go for gonadotropin IUIs and then come for IVF. Doesn't work that way. So you have to see the age of the woman, the duration of infertility, as well as other factors. But even then, what is the success rate that we're talking about in an IUI? Each cycle, the max that you can go up to is between 18 to 22%. So why is it? You are telling us, now woman will sit in front of you saying that you have checked my ovulation, you have given me medication, I've produced 2 follicles, you say my husband's sperm is fine, my tubes are open, why haven't I conceived? The reasons are as follows. Your total motile sperm count has to be more than 10 million. If it's less than 10 million, your chances in IUI are going to be low. The survival of the sperm also is important, which is why a sperm function test will answer some of the questions if a woman hasn't conceived with IUI. Your normal spermatozoa also has a small role to play. And like I said, the total motile count that has to be inseminated definitely has to be more than 5. You will see some papers which are saying the motile count is 1 million, 5 million. But what consistently gives you the right success is more than 10 million. Also, the sperm is given, it's prepared, but the clinician takes their own sweet time to go to the IVF because they're busy in their OP. Doesn't work. As soon as the sample is processed, it should be inseminated. What are the other causes? We don't know the oocyte quality. We're only seeing a follicle. We've seen the collapse of the follicle, but we don't know the sperm quality. We don't know the oocyte quality. We don't know the tubal motility. We don't know whether fertilization has occurred or implantation or whether there's aneuploidy. So what do? You have done about a couple of cycles. Before you do further cycles, you really want to know what else can we do? Sperm function test. A semen analysis, as we all know, is only at that point. There are so many pitfalls to how to analyze a sperm sample. We do not know because the semen analysis has no prediction to fertility. Sometimes you'll say you need ICSI, and after 2 or 3 months, the woman comes back getting pregnant. All it needs is one sperm. So an analysis doesn't tell you whether they are capable of actually getting pregnant or not. So there's a poor prediction. Morphology is poorly correlated. We do not know about the acrosome reaction. We do not know the zona binding, which is so important for fertilization to occur. And obviously, each lab has its own way of assessing it. Sperm function tests were developed to detect abnormalities in sperm survival, transportation, fertilization, prediction of pregnancy rate, and also to target therapy. Sometimes based on the sperm function test, you can actually tell them whether the IUI is suitable for them, whether they need double IUI or any other interventions. There was one bit I spoke about laparoscopy. We said that laparoscopy is not required for unexplained infertility in terms of diagnosing it. But should you do laparoscopy, even in somebody who you think is unexplained, more than 30% of the time you find a pathology. In fact, there are some papers which say up to 50% of your laparoscopies you will find a problem. And most of the problem ends up being endometriosis, followed by adhesions. And the one thing that you have to remember is if you're doing a laparoscopy, your laparoscopy should not be just for diagnosis. Your laparoscopy should be therapeutic as well. And we all know that mild to moderate endometriosis, if you do a proper excision of your endometriosis, you're actually increasing her natural chances of pregnancy. Not just about her chances with fertility, her natural chances are also improving. Now, this was a prospective study which looked at laparohysteroscopy, and like I said, more than 36% to 40% they found pelvic abnormalities. If IUI fails, then what do? You have done everything that you have understood about IUI. What are the parameters? What are your goals? But you still haven't managed to succeed. Then it's IVF. Why IVF? Well, all the things that we don't know in IUI, at least we are able to detect in IVF. But yes, it's invasive, it's expensive, and it has a shorter time to pregnancy. But it's not easily accessible. Not because centers aren't there. Center is there in every street nowadays. The reason why it is not accessible is because of the cost that is involved. What should we do? Should we do IVF or should we do ICSI? There is no difference. The reason why people prefer to do ICSI in unexplained is because they are scared about failed fertilization. They haven't conceived even with such good IUI cycles, even with such good ovarian stimulation protocols. So there must be a problem in fertilization. Let's do ICSI. But studies have shown there is no difference in terms of your pregnancy rates. But there are certain prerequisites before you go for IVF. Just because unexplained everything is fine, you go straight for IVF. No. You have to relook at things always, at every step. Look at the uterine cavity, reassess their hormonal balance, look at their ovarian reserve, specifically do a sperm function test, and give them antioxidants to see whether that can help. Understand that I'm not talking about DFI. There is no role for DFI in unexplained in the first cycle of IVF. So how do you optimize IVF? Because IVF in all ways, in a person's mind, in a couple's mind, IVF is the end of the road. Some people do not consider IVF not because they cannot afford it. Some people consider, oh my God, that is the last bit. What if I fail in this? I won't have any options. So they try to avoid even taking that last step because they're scared. What if this also fails? So for us as well as the couple, the first IVF should be their last IVF. Like how they say in laparoscopy, in endometriotic surgery, your first laparoscopy should be the best laparoscopy, correct? That's how it should be even for IVF. And that's where we come into the picture to ensure that we are optimizing their chances. What are we needing to optimize? The oocyte, the sperm, and we have to look at the fertilization as well. So as much as possible, try and improve the quality of the egg and the sperm. Now, we are also calling IVF therapeutic and diagnostic, like how laparoscopy is wired, because you're able to assess the sperm, you're able to assess the oocyte, you're able to look at the fertilization, you're able to see the cleavage and the division and everything else. And you're also causing a union there. If you think there's a problem in terms of fertilization, your ICSI is going to do the job for you. So, if you have a woman who's less than 33 years of age, good reserve, normal semen analysis, unexplained, what do? You do timed intercourse because she's young. And remember, this is not evidence-based. This is Indian psychology and Indian economy-based. You have done timed intercourse for 3 cycles, haven't conceived. You go for IUI. You have done 3 to 6 cycles. In between, if you think there's a possibility, you do a lab to see whether you can also increase her chances of pregnancy. IUI doesn't work, you go for IVF. IVF, again here, it dichotomizes. What happens in IVF? IVF is not 100%. Why are we saying concentrate on your IUIs, get your protocols well? Is because we don't want a woman to go towards IVF. She spends so much money and you still give her a 40 to a 60% success rate based on what interventions you're doing. Is she going home with a baby? Is there a 100% guarantee? No. So what happens? You've done IVF. You have put 4 blastocysts at different intervals. I don't mean putting 4 blastocysts at one place. I meant it either in 2 or 3 different attempts. You've put 4 blastocysts, they still haven't conceived. This is recurrent implantation failure. What happens then? PGT. You do ERA. Even then, what is your success rate? Right now, even with PGT and ERA, you're looking at 70 to 75% take-home baby rate. You still haven't crossed the century mark. Now, what if you have somebody who's older or who's got a borderline and a poor ovarian reserve or a borderline or a poor sperm parameters, if they've had absolutely no prior treatment? And there is obviously a reluctance to go towards IVF. Give them 2 or 3 cycles of IUI, but you have to be very conscious of the time here. No pregnancy, it's IVF. They've had earlier fertility treatments, they haven't conceived. You need to do IVF straight away. And again, if IVF, you put back 4 blastocysts, no pregnancy, then yes, the next step is PGT and ERA. Unfortunately, when it comes to fertility treatments, this is where we have data. The talk about stem cell therapy, mitochondrial exchange, all of these are not actually for routine practice. Right now, when we are talking about effective fertility care, we stop at PGT and ERA. So summary, minimum number of IUI is 3. Maximum number of IUI depends on factors. If ovarian reserve is normal, age is less than 32, 33, you can go up to 6. If average reserve or the age is 33 to 35, 3 IUIs. If below average reserve or she's older, then IVF is better. But if she's never had treatments, you can consider up to 2 IUIs. If poor reserve, age is above 35, it's IVF ICSI. So when you're looking at ovarian reserve tests, you have to look for her scan, see how many follicles she has. If her follicle numbers are low, then you have to cater the number of IUIs based on her reserve. Then should IVF be considered when she's older, when her AMH is less, when her AFC is less, when her FSH is above 8 or 9, severe endometriosis, adenomyosis, and fluctuating sperm parameters. This one study actually opened a lot of things. People who we consider as unexplained could actually be less reserve. which is why, even during the morning sessions, we were talking about when you are seeing a couple, it is best that the first ultrasound, the baseline ultrasound, is done by us and not a radiologist, because you will be able to see number of follicles, what is the volume of the ovary, what is it that you're looking at. You're looking at your uterus, you'll get a 3D ultrasound, see whether there are any anomalies. Your assessment is definitely going to be better than what a radiologist is, who's only going to be looking to see for pathologies. Here you're looking to plan her management. So your assessment is definitely more important, and that is where your skill has to lie, which is why we got the expert to speak to you about how to actually understand and learn about ovarian reserve. This particular trial, we are waiting for the results of this trial, and this particular trial is going to give us the answers whether in unexplained infertility, should we look at IUI, and if it doesn't work, then IVF, or should we go straight for IVF? There's still going to be some more data that is going to come back. Thank you very much.
Thank you, Dr. Durga. That was superb and an excellent talk, very educative, and you gave us clear messages how to go about dealing this enigmatic topic of unexplained infertility. Thank you for simplifying it for us.
Thank you.
Thank you, ma'am, for sharing valuable knowledge with us. I would like to request our chairpersons to please felicitate Dr. Durga Rao.
Yeah.
For our next session, I request Dr. Rajeshwari Pawar to please introduce our next speaker, Dr. Sonal Panchal.
If I have to talk about Dr. Sonal Panchal, let me just tell you that 20 years back, when we first attended our fertility conference, she was still giving talks. And here we have her here after 20 and 25 years. Added to, physically, she looks all the same, not put on weight as much, but definitely improved or sort of compensated by increasing her enormous experience that she has. I thank Dr. Nilesh for having invited me here, because we fetal medicine specialists hardly ever get to attend fertility conferences, though we do practice fertility because patients do come. And so I'm so very fortunate. And when I say Dr. Sonal Panchal, I think I would correct myself. I would call her the Dr. Sonal Panchal. She's been a master as far as ultrasound infertility is concerned. She's been on the international arena as well. She's been a professor in the universities in Croatia and Bosnia. She is also the director of the Ayandonal School of Ultrasound, and she conducts master's courses for ultrasound infertility, even in Dubai. Here's Dr. Sonal Panchal for you.
Thank you very much for those really kind and loving words. To start with, of course, good evening, good afternoon is the first thing that I need to tell you. But after that, thank you very much for this invitation to the OASIS team. And truly from my heart, congratulations to you, Dr. Durga, because developing so many centers with this quality of work is a very hard task. And especially with a new perspective in this day, in today's era, where everybody's running after numbers, to go after quality is a big thing. And then to mentor so many people is really an even difficult task, done very well by you. Thank you very much, and congratulations to you also, Dr. Nilesh. And that's where I start my talk. And the talk is on ultrasound in infertility, as you know. The topic is really very wide. Dr. Nilesh has been really kind to me to allow me to talk for 40 minutes, but I'm feeling that also may be quite restrictive. So what I'm going to do is I'm going to not talk about anything else but the cycle assessment, or as we know, monitoring the ovarian stimulation. And of course, wherever possible, I may discuss a little bit more about some endocrinology, but yeah, let me see how much I can do. We know that planning of ovarian stimulation protocols and assessing the follicle and the endometrial growth to plan the trigger and the further treatment, these are the crucial steps to the success of an ART cycle. When I say ART, it is all assisted reproductive technology, which includes IUI and IVF both. And this can be done by multiple endocrinological tests and 2D ultrasound, but it can also be as effectively or probably even more effectively done with ultrasound and Doppler. That is one point where I don't only agree with Dr. Durga, I go one step further. When she said, don't send your first scan to a radiologist, I will tell you, don't send any of your cycle monitoring scans to radiologists, because unfortunately, our radiology friends still are not so much interested into the reproductive medicine, and they probably don't like the reproductive endocrinology at all. I have to admit I'm a radiologist. I'm sorry. Going further than that now, follicular growth, maturity, ovulation, and luteal phase changes are the continuous changes involving multiple hormones and can not actually be sharply divided into phases, but just for the sake of convenience of discussion, we would divide it into three different phases of the cycle. The first is what we call a baseline scan, which we do to decide the stimulation protocols. The second one is the scan that is, I would say, pre-ovulatory scan, but that's also not the correct word. Pre-trigger scan maybe, and it is actually to assess the follicular maturity and the endometrial maturity. And the third one, absolutely essential, though we are not doing, and I'm sorry, maybe I might not be able to cope up with the time to discuss that, but it's very important to look at the luteal phase scan, because that is the scan which allows you to look back into whatever you did during the cycle. Did you do something wrong? Did you miss something which has led to failure for the patient to conceive? So that is a very important scan, though let's see how much we can cover. So the first scan, the first scan that we talked about is to decide the stimulation protocol. And if I say I want to decide the stimulation protocol again, I think I will have to quote you several times. Please don't mind that. So as she rightly said, that when you do ovulation induction, when you do ovarian stimulation, what are you afraid of? As she rightly said, it is gonadotropins which is to be used. And if I say so, my first worry is OHSS. My second worry is, what if there is a poor response and the patient, I cannot complete the cycle, I have to cancel the cycle, and the patient gets annoyed about and angry about the expenses made. So that is the reason you actually need to individualize the stimulation protocols. And for individualizing the stimulation protocol, there are two things which are important. One is the ovarian reserve, and the second is the ovarian response. These two terms have been used as synonyms for n number of years. There were some studies which started coming up after 2005, which started differentiating between the two. But let me tell you, though even today there are some studies which still use these two terms interchangeably, but they are really two different things. Reserve is what tells you about how many follicles you are going to get at the end of stimulation, and that is decided by the number of antral follicles and the ovarian volume. Whereas the response tells you what doses of gonadotropins will you require to produce those expected number of follicles, and that is dependent on the ovarian stromal flow, and we'll go further in both. But before that, I want to tell you that these are to be assessed on the baseline scan, day 2 or 3 of the cycle. And we call it a baseline scan because we know that at that time, not only the ovarian steroids, even the FSH and LH are close to their baseline levels. The levels are not high.
And the reason why I said day 2 or 3 of the scan, and this is what I need to emphasize, because most of us, we believe day 2 to day 5. Day 5 is no more a baseline scan. Most of the cycles, the dominance of the follicle has already been selected, and then we cannot call it a baseline scan at all. So it has to be day 2, 3 of the cycle. And there are very, very important and very subtle and very not very commonly talked about points which I want to make clear. No matter, even if there is a bleeding, you can still do a vaginal scan. You must do a vaginal scan only when you are assessing the cycles, when you are assessing the patient for reproductive medicine. If I say that the dominance of the follicle is selected, most of us, we believe, and this is what has been documented in the old literature, follicle which is 10 millimeters is a dominant follicle. That is where I want to add something, and that is, it is not only the follicular size, it is the blood flow to that follicle which is important. Remember that as soon as the follicle achieves dominance, it starts pooling blood vessels towards itself. And you can actually, if you do a good scan, you can see that single vessel directly leading towards that follicle. And not the entire follicle will be covered with the blood vessels, but you do definitely see some blood vessels surrounding that, surrounding that follicle, which tells me, yes, this follicle has reached dominance. And it has been observed that there may be follicles which may be even 8 or 9 millimeters, but they still may be dominant, and this is very, very important. Why is it important is what I want to tell you before I go to the next slide, and that is that many times it happens you see 2, 3, 4 follicles of 8, 9, 10, 11 millimeter on your scan before you start gonadotropins. You're worried what is going to happen to that. And then that's where you must put on the flows. Most of the times it would be 1 or 2 follicles which would show you flow, and these are the 2 dominance follicles. Don't be afraid about the rest of the 2 follicles. There's another important thing about the dominant follicle, and that is, if I'm doing a baseline scan and if I'm seeing a dominant follicle, if I'm seeing a follicle which is 8, 9, 10, 11 millimeter, if I put on a Doppler IC flow, which means it's a recruited follicle of this cycle, which means that it's an early recruitment of the follicle, which means that the FSH of that patient is rising. I said rising, it is not high. So that means you can diagnose not diagnose, but you can predict ovarian aging even before your FSH reaches that cutoff, when we say your ovaries have failed. So that is very important. Now, if it comes to the antral follicle count, how to count them? The correct way to count is locate the ovary and just scroll across eyeball and count the number of antral follicles. Very important point here is, don't rotate the probe. Locate the ovary, span your probe so that you lose the vision of the ovary, come back in the same direction across the entire ovary till you lose the vision, eyeball, and count them. And the studies have shown that whether you use a 2D or you use a 3D, as long as the number of follicles are up to 12 to 15, both the methods are equally accurate. But if the number of follicles are more, that's when you should use those sophisticated softwares like 3D with Sono ABC, which color codes every follicle. Of course, some post-processing may be required, but it color codes every follicle, so there's no overcounting. If you do a proper post-processing, you'll also know the correct size of the follicles and the correct number. Is that enough? Is just AFC enough to be used as a measure of an ovarian reserve? As far as the practical approach, as far as the practical use is concerned, probably yes, because there are, of course, because of the time constraint, I've not put, but there may be at least 25 plus references which have compared AFC and AMH and which have shown that both are almost equally reliable for the assessment of the ovarian reserve when it goes to the stimulation cycles. Number of retrial, I've put some references here. Number of retrial oocytes correlates only with the antral follicle count and the ovarian volume. AFC and the ovarian volume provide direct measurements of the ovarian reserve. For the poor reserve patients, a model including AFC and AMH was found to be almost similar to that of using AFC alone. For hyperresponse, AFC is used to predict the hyperresponse and thus using safe, successful stimulation regimes and to prevent OHSS. In a patient, in one study where we compared normal group and the PCO group, two markers AFC and AMH. For two AND results, the number of oocytes retrieved and the number of follicles larger than 12 millimeter on the day of trigger, both the markers for both the groups did not show statistically significant difference in the accuracy and efficacy. So since then, for all practical purposes, we are using only FC. Yes, AMH, I don't say is useless. It is required. It may be an additional test for you to decide the quality of the follicle also, but is not an absolute essential if you, to start ovarian stimulation for a patient for IUIs or even for IVF for that matter. AFC is highly, even when we talk about PCOS patients, for anovulatory patients, AMH, but for if you think of AFC, it can be used for anovulatory patients as well as for the ovulatory patients. So AFC is highly sensitive in all the phenotypes. When we are talking about endometriosis, non-operated cases, age and AFC. When we are talking about all the post-surgical cases, it's AFC which is very reliable. And then there is okay. Another paper also says AFC represents the most useful ovarian response marker for the controlled ovarian stimulation. Both are they correlate both the markers, they correlate very well. So I again repeat, I don't say no to AMH, but for all your practical purposes, even if you do an AMH, you are going to still do an ultrasound before you start gonadotrophins. So why not try and get the information from the AFC itself? You may add AMH if you like to, but it doesn't become absolutely essential, especially when it comes to IUI cycle. When you have to decide, I'm going to go for IUI, I'm going to continue with IUI, I'm going to go for IVF, that is when you may get an AMH done, but not for taking a cycle on for ovarian stimulation. When it comes to the ovarian volume, there I don't need to give you any justification. You all know smaller ovaries, lower reserve, higher chances of cancellation of the cycle, larger ovaries, higher chances of hyperstimulation, maybe PCO. How to measure is very important. There are people who measure the ovaries, locate the ovary, take two sections, any random diameters is not your ovarian size. Locate the ovary, rotate your probe, find out the longest plane. On the longest plane, scroll across the entire ovary, find the longest section, bring it in the center of the image. So it should not be in the periphery somewhere. Bring it in the center of the image and then rotate your probe. So freeze it on one frame of the dual frame. Rotate your probe 90-degree anti-clockwise, no other movement at all, and that is your correct transverse section. So take the longest diameter perpendicular to the long diameter and the transverse diameter parallel to so the largest transverse diameter parallel to the x-axis is your correct measurement of the ovarian. These are the correct three longest orthogonal diameters to calculate the ovarian volume. Or if the ovary doesn't appear round or oval, you can also use Vocal, the 3D Vocal software, to calculate the ovarian volume even more reliably. So that is about the reserve parameters. Coming to the response parameters, what does the literature say? Measurement of the ovarian stromal flow in the early follicular phase is related to the subsequent ovarian response in the IVF treatment. VI, FI, and VFI, vascularity index, flow index, and the vascularity flow index, which are the 3D power Doppler indices, which tell us about VI, tells us about the abundance of the flow in the volume. FI, flow index, tells me about the average intensity of the flow in the ovarian volume. And VFI, vascularity flow index, which is a composite value of the two, which tells you about the perfusion of the ovary, are significantly related to the ovarian response to stimulation. There's one other study by Professor Kubasik, and she has said if the FI is less than 11, patient is going to be a poor responder. Between 11 and 14, good responder. More than 15, she is a better responder. Even in cases of endometriosis, it has been shown that ovarian stromal blood flow
by 3D power Doppler ultrasound in women with endometriosis may provide an important prognostic indicator in those who are undergoing IVF. And even in the PCO patients, it's been shown that it is the VI and the VFI, which are the two parameters which are much higher in the PCO patients as compared to the normal patients. And we all know that it is these patients, it's PCO patients who are more likely to go into hyperstimulation. But we also know that there are PCO patients who behave as resistant PCO. And what is that cause? Of course, we are not going to go into the discussion of PCO. PCO is a very, very lengthy and a very complicated topic. But even in the PCO patients, the patients who have a worse form of the disease, who have higher insulin, who have higher androgen level, these are the patients who are going to have more stromal flow. So they are more prone to get OHSs. Whereas if you are looking at the obese patients as compared to their normal weight counterparts, they are going to have higher resistance in the stromal flow. And therefore, these are the patients who are going to behave as resistant PCOs. If you may think I'm talking about all 3D power Doppler parameters and who's going to use it, but it's same for the 2D parameters also. Ovarian stromal PSV after pituitary suppression is predictive of ovarian responsiveness and the outcome of the IVF treatment. Those who had low stromal PSV in the early follicular phase were poor responders. And there is another, from a lot of different literatures and our experience, we have also found that whenever the ovarian stromal RI is less than 0.58 and the PSV is more than 10 centimeters per second, patient is a hyper responder. These are the patients where you should start with lower doses of stimulation. Whereas when the RI is between 0.6 and 0.7 and the PSV is between 5 and 10 centimeters per second, these are the patients who are normal responder patients. That means in these patients, you can start with normal, the regular, the standard doses of stimulation. And then there are patients who have a stromal RI of less than 0.7 and a PSV of less than 5 centimeters per second. These are poor responders. In these patients, you have to start with higher doses. Now, what is important here is, and this is a very important concept, a patient with a good reserve may also be a poor responder, and a patient with a poor reserve may be also a hyper responder. So there may be 3-4 follicles, but the flow is very good. You may just have to give 3-4 doses of gonadotropins and patient produces nice 2 or 3 follicles. Whereas patient may be a severe PCO and you continue stimulation for 15 days, and that will be a difficult task to produce follicles in this. And therefore, this concept of reserve and response together is very important. How to measure the stromal flow is the second question. And when that comes, it is a bit tricky, that has a little bit of a learning curve. If you remember the image that I showed you for the dominant follicle, you saw there was one long vessel which continued from outside the ovary. Naturally, it is either the ovarian artery or it is a ovarian branch of the uterine artery. We know that there are two main feeder vessels for the convenience of the discussion, just for ease to name those vessels. I'll say these are the two main feeder vessels, or you'll say these are the two main hilar vessels, and you will not measure the flow in these vessels. So you have to locate the ovary, switch on the Doppler. Once you switch on the Doppler, if you right away see a long axis of any vessel, you can easily trace it outside. But if you don't, rotate your probe and find out which is the plane where you're finding that long vessel, and then avoid measuring the flow in that hilar vessel. From that, scroll your probe on both the sides, find out bright color spots in the stroma and away from the follicle, and measure the flow in that. Of course, there may be multiple vessels, not one. You have to measure the flow in at least 3 vessels and take the best combination of lowest RI and highest PSV for the decision on what should be the dose. Why am I saying on the decision of what to take the dose? Is because we use this system, which is a baseline scoring system, to decide the stimulation protocols. And we have been, as you can see here, the publication date dates back to 2016. We have been using the same method since so many years. Before that, we had a little cruder version of this, but I'm proud to tell you, in spite of using only gonadotrophins for all our IUI cycles as well as for our IVF cycles, even in an era where we didn't have antagonists, we had only HCG to be used as a trigger. Even then, I have not documented a single case of OHSS in my clinic. Not one case, and this is a duration of 23 years since end of 1999. So that is where, that is what talks about the effectivity of that protocol. So what as I told you, it was a bit complicated. We have simplified this in 2016, and you do a baseline scan and you age BMI of the patient and find out the AFC ovarian volume, stromal RI, and the stromal PSV, and just put the values into the relevant boxes and find out what is the score. Say, for example, there's a patient with age of 32, BMI of 27, AFC of say 13, volume of 6, maybe stromal RI of 0.7, and stromal PSV of 4. This is just for the ease of calculation. I don't have to count various numbers and remember. So 3, 3, 3, 9, 9, and 6. So it is 15. That means the score comes to 15. And these are the decided doses for the stimulation depending on what is the score. And these are the doses for IUI, these are the doses for IVF fresh cycle, and these are the doses for the IVF frozen cycle. For the frozen cycles, we can afford to give a little higher dose, we can afford to have a few more oocytes, because we're not going to do a transfer. The chance of HSS is very little. And when we are talking about the efficacy of this method, I would just want to show you this, which this is what, the study was published for 1517 IUI, 1570 IUI cycles, 350 IVF cycles. After that also, we continued doing it. We are still doing it. At the analysis, when we did analysis with 6,000 patients, 30 to 40% conception rate per cycle, fresh cycle IVF or IUI, and 0 moderate to severe OHSS, and 2 to 3% of tween pregnancy rate is what is important. We avoid complications and we can plan better stimulation protocols. You start stimulation naturally. On the day when you start stimulation, you are going to do a scan, and if there is any follicle which is larger than 9 or 10 millimeters, always put on a Doppler, confirm it is a dominant or not. If there is a dominant follicle, that is when we know that dominant follicles normally have a growth rate of 2 to 3 millimeters a day. Of course, the entire range is 1 to 4, but we generally take it as 2 millimeters a day. Accordingly, calculate when that follicle is likely to reach 17, 18 millimeters and call that patient on that day. But when you start stimulation with gonadotropin, if there is no dominant follicle, all the follicles are smaller than 9 millimeters, then you directly call them after 5 days of stimulation. When you call them on the 5th day of stimulation with gonadotropin, and you see that there is no response. Now, this is a very important point. Most of us, when we see the follicle is not growing, we say no response. And this is not right. Even in absence of the follicular growth, if the endometrium is growing, that FSH is working on the granulosa cell, estrogen is being produced, how can you say there is no response? The patient is responding. If the endometrium is growing, tomorrow, day after, the follicle is also going to grow. So don't change the dose. Only if the follicle and the endometrium both are not responding, only then increase the dose. And how much would you increase the dose? If there was no response on the 5th day and the primary score was less than 10, that means low reserve, low responding. That's when you directly add, and this is about RFSH all. That's when you add 75 international units of RFSH on that 5th or 6th day of the stimulation when you see her. But if the primary score was between 10 and 20, that is when you see on day 5, there's no response, but don't increase the dose. You may call her after another 2 days. On day 7 of the stimulation, if you see that there is no response, only then increase the dose by 37.5 to 75. If the AFC is more than 20, only 37.5. It's between 14 and 20, say 50 units. And if it is less than 14, then you can add 75. If the score is between 20 and 22, the primary score, you don't have to do it again. Primary score is between 20 and 22. See on day 5, these are PCO patients, naturally. See on day 5, no response, don't increase the dose, continue same dose after another 5 days. You may scan in between if you want to. But don't increase the dose till 10th day of stimulation. On the 10th day also, if you see no response, only then increase the dose by 37.5 RFSH. And if the score is more than 22, severe PCO patient, in these cases, you see on day 5, don't increase dose. See on day 10, don't increase dose. Call her after another 4 days. Even on that day, there is no response. That's when you increase the dose by half the stimulation dose, maximum 37.5. And you will not have to increase the dose for the second time if your baseline score is correct. Whereas if it's an IVF cycle, it is in this patients, if naturally for them we start stimulation on day 2, we cannot prolong the cycles so much, so that when we see on day 5 of the stimulation, if there's no response, we will increase the dose by 75 RFSH plus 75 LH or 150 HMG. Score between 10 and 20, see on day 5 or 6, no response, we will increase the dose by 75 RFSH. And if the score is more than 20 and on day 5 or 6, that means it's a PCO patient, we will only increase 37.5. Now, what is very important here is that only in one case I have shown that we are going to add LH, right? Not in any other cases. Why is because when the score is very low, we know that RI and PS is also low. Now that is where comes the role of LH. We know that the ovarian stromal flow is a function of VEGF and it is a function of LH. Of course, there are other biochemicals, but these are the two which are of bit importance to us. Now, when we are talking about LH, it is LH which leads to neoangiogenesis, it leads to catecholinergic stimulation, it leads to cytokine and leukocyte activation, and therefore it leads to more blood vessel formation, it leads to low resistance flow. If I see that the baseline score is low, very low, that means RI is high, PSV is low, which means that either LH is not perceived or it is less bioactivity, it is less bioactive, or it has a polymorphism, and it is in these cases that LH supplementation is required, and it is only these patients who will respond poorly. And this almost fits into what is shown in the Poseidon criteria also, because if you look at Poseidon group 1 and 2, the ovarian reserve parameters are normal, but the patient doesn't respond, and that's where we are going to add LH. If you have measured the scores, if you have assessed the score, the blood flows, you might have been able to diagnose this earlier. Coming to the pre-ovulatory scan now, once you have seen that the follicle has started growing, that's when you need to measure the size of the follicle. Before I go to this slide, I want to show you this slide, and that is how to correctly measure the follicular diameter. Again, that is where I have quite a complaint against majority of the people, because we see the follicle, we rotate the probe, find out how this looks rounded, 1, 2, 3 diameters, and this is the mean diameter of the follicle, and that is not the mean diameter of the follicle. Locate the follicle, rotate the probe, confirm it is oval or it is round. If it is oval, just like you did for the ovary, take the longest diameter perpendicular to the long diameter, and on the other plane, take the transverse diameter, and the mean of that is your correct mean follicular diameter. But if the follicle is absolutely rounded, that's when you can take only one diameter, and that has to be always an AP diameter, not a side-to-side diameter. For the physics of ultrasound, you know that the side walls will never be as clear as the anterior and the posterior wall, and therefore this is the way you measure the follicle. We all know that a follicle which reaches about 18 to 24 millimeter, these are the follicles which are going to rupture. Of course, to assess the follicular maturity, the follicle quality, I would say, not the maturity, you should always see the Dopplers. But before you see the Dopplers, you will see a perifollicular halo. And it is this halo which tells you, yes, it looks like ovulation is about 24 to 36 hours away. In some follicles, you may also see a cumulus. Why I say some follicles, it's present in every follicle, but it is a very tiny solid projection, and therefore can be seen only if you have optimized your image well. You are using a nice zoom image, and you are patient enough to scroll across the entire follicle, at least in 2 planes. Only then you will be able to, though there are documented studies which says majority of the follicles beyond 15 millimeter will show a cumulus, but
In practice, people don't see it. One more point again, and this is very important. If you see a crescent like shadow in the follicle, this is not a cumulus. Cumulus is a cell mass, it is not a cystic structure. It has to appear like a solid, tiny solid projection. I don't want to name the companies, but there are companies in their what is it called, monographs. They have put a cystic structure, a picture of a cystic structure like that, named it as a cumulus. This is not a cumulus. Please don't get carried away with wrong things. Then it is about 6 to 10 hours before the ovulation. Some studies say 5 to 12 hours. You start seeing low level internal echogenicidity parallel to the follicular wall. And this is because the separation of the innermost cell layer underneath which the cumulus oophorus complex is secured. So this tells you it is an impending ovulation. What is there a role of 3D when you are assessing the follicular size and the quality? Not when you have a single follicle, but when you actually have multiple follicles. That is when all the follicles are compressed by each other, and that is when none of the follicle is round. Even if you work hard and take 3 diameters, you will not get the correct size of the follicle. That is where sono AVC is very important, because it is sono AVC which measures, which tells you not only the x, y, z diameter, mean diameter, and the volume of every follicle. It actually does something more than that. And what is that? The first column, if you see, that is a volume release diameter. What is that? If I have a volume of this size, 6.26 cc, and the shape is absolutely irregular because the follicle is compressed from all the sides, if I have a clay of that shape and I roll it and make it a sphere, what would be the diameter? That is that diameter, which is the volume release diameter. And you can see that it is much different than the mean diameter. Therefore, it's that diameter which is important to us, not the mean diameter. So that is the importance of sono AVC or the 3D ultrasound when it comes to multiple follicular development. Moreover, the follicle diameter of between 18 and 24 usually correlates with a volume of between 3 and 7 cc. But that, why is that important? There are old literature evidences which say all the follicles up to 12 millimeter in diameter or 1 cc in volume will give you fertilizable ovum. A recent study of ours have shown even the follicles up to about 0.6 cc have given us fertilizable oocytes, and this is especially useful when you have very poor reserve patients. So sono AVC is very accurate in efficient way to measure the ovarian volume and even the follicular volumes, ovarian follicles, and may help establish new criteria for the timing of HCG based on the follicular volume itself. Now, coming to what happens to the blood flow, we have talked about the size and the 2D, and we go to the Dopplers. I told you that the follicular vascularity starts developing soon after the dominance, and it keeps on increasing 2 days before ovulation. 48 hours before ovulation, this vascularity shows lowest RI. It starts covering more than 2/3 of the follicle, lowest RI. And that time correlates with the final rise in estrogen. So it is the pre-ovulatory perifollicular RI which correlates with the estrogen levels. After that, the PSU of the follicle starts rising, and when the PSU of the follicle reaches 10 centimeters per second, that's when the LH surge is going to start. And with the rise in LH, this PSV will keep on increasing. So the perifollicular pre-ovulatory PSV correlates with the LH levels. How to measure the flow? We are going to use only 2D Doppler. Once you switch on the Doppler, your scrolling has to be very steady and slow, otherwise you will have a lot of artifacts, and you have to scroll the entire follicle in both the direction, longitudinal and transverse, and eyeball and judge how much of the follicle is vascularized. But if you are not sure, it is always better to go to 3D, because 3D gives you actual idea about how much of the follicular circumference is covered by the vascularity. And this is very important, because when the vascularity is more, estrogen is better, which tells you that it is a better quality follicle. Moreover, there are also studies which have shown that if the vascularity in the follicle is surrounding the follicle is not sufficient, oocyte inside is hypoxic. And if that is hypoxic, there is a high chance of chromosomal abnormality. There are lots of studies which have shown that if the vascularity is good, the chances of chromosomal abnormalities can be decreased. One of our studies is also in process. It is like a study of more than about 10,000
positive pregnancies, and we are assessing the role of Doppler to avoid the possibility of chromosomal abnormalities. So if we put together everything, follicle at least of 16 millimeter when it is a gonadotrophin, preferably 18 or 20 for CC cycles, you might have to wait till 22, 24 millimeters before you get the flows and before you develop the endometrium also. Blood flows must cover at least 2/3, preferably 3/4 of the circumference, RI less than 0.48 and PSV more than 10. These are the minimum parameters for the follicle. Coming to the endometrium is can I take 5 more minutes after my time? Yeah, thank you. So, yeah, it is the endometrium, which is a receptor organ for the estrogen and progesterone. As the estrogen starts rising, we know estrogen starts rising after the dominance of the follicle. So, the estrogen is being secreted before that also, but the rise is quite faster. It is then that the endometrium starts becoming multilayered. The normal growth rate of the endometrium is also important. Remember, follicle or endometrium, whatever the size is, but if it is not growing, then it is not live. Either it has to grow or it has to change vascularity, only then it is live, only then it is good in quality. So the normal growth rate in the mid proliferative phase is 1 to 2 millimeter per day. It decreases a little just before ovulation, 0.5 millimeters a day. When the endometrium, and you will see a triple line endometrium, sometimes with anechoic areas in between, sometimes with echogenicities in between. Which one is better? None is better. Both are equal. Why? Because it correlates actually with the estrogen levels. When your estrogen levels actually reach approximately 1 to 2 mature follicles, that means like about 100, 150 picogram to about 300, 300 to 400 picogram per ml. That's when you get a B grade endometrium, where it is multilayered with intervening areas which are severely hypoechoic or anechoic. As the estrogen level increases, you start seeing echogenicities between the line. These echogenicities are not more than that of the normal anterior myometrium, and it till the estradiol levels reach approximately 900 to 1000 picogram per ml, you still see a grade A endometrium. That means it is equivalent. When you say grade A endometrium, you believe that there may be 3, 4, 5 mature follicles. But when the estrogen level rises beyond that, usually we discard. I mean, we actually we are not happy about seeing that isoechoic endometrium, which is homogeneous, but that is also estrogen predominant endometrium. That is a normal endometrium that you will find in majority of the PCOS patient, as long as it is isoechoic to the myometrium. It is not hyperechoic, it is a very good endometrium, provided it shows good vascularity. The estrogen level on the endometrium reflects as either increase in thickness, change in morphology, increase in vascularity and cervical mucus, and also hyperechogenicity of the cervical glands. Why I am saying this is because sometimes it happens that follicle, the ovary may be posterior to the uterus, it may be far from the probe. Remember, there's a limitation of the color Doppler technology. Any structures which are far from the probe, even if the flows are there, you will not be able to document that. So if you cannot assess the follicular flow, if you are seeing that the endometrial parameters are good, which indirectly tells you the estrogen level is good. Not only that, when we are assessing the endometrium, it is not only about the estrogen levels, it also tells you this estrogen is also acting on the endometrium. That means it tells you that what is the receptor development, how is the receptor development. It tells you whether this estrogen which is present in the blood, of which I'm just measuring the immunoactivity, whether what is its bioactivity. So that is important. Then again, just like the follicle, it is important how you measure the endometrium. Never measure the endometrium in an image like this. Always bring the endometrium right in the center and enlarge the image, zoom the image, and then measure it from outer margin of hyperechoic to outer margin of hyperechoic, perpendicular to the central line of endometrium. Now, these are minor things. This appears very basic, but I think it is very, very important. That is the reason why we all don't stand on the same page. We are not on the same page when we are talking about the follicular and endometrial monitoring. Then you have to put on the Doppler box, just large enough to include the entire endometrium, and look at the blood flows. The blood flows which are reaching the inner layers of the endometrium is what is called zone 3 and zone 4 vascularity. And it should cover at least 5 millimeter square area. If you cannot measure the 5 millimeter square area, if there are at least 5 vessels closely placed to each other, not widespread,
closely placed to each other from anterior, posterior, both the aspects, reaching the inner layers of the endometrium, that is a sufficient area vascularized, and should have an RI of less than 0.6. Along with that, you must also check the uterine artery flow, and the uterine artery PI must always be less than 3.2. Only if these parameters are achieved, that means your endometrium is good. If you are going to do an IUI or a fresh transfer IVF, these are the parameters which are required with the follicle. But even if you are doing frozen transfer, these are the parameters which are required before starting progesterone. Why is that so? Is because the endometrial blood flow is very important to us. If it is not present, it is a strong indicator of failure of implantation. Even if the implantation occurs, there is a high chance of pregnancy if the vascularity has not reached the endometrium. And you can see here the chances of, not only the chances of pregnancy are very high, but the chances of abortion significantly decrease if you see vascularity reaching zone 3 and zone 4. Apart from that, nowadays we are talking about the 3D and the volume. The volume of the endometrium is especially important in those cases where you have either a persistently thin endometrium, you are confused whether to transfer or not, and the endometrium is good or not, and especially when the vascularity is also present. That is when, if you don't have a good thickness of the endometrium, you should take a volume. Sometimes it also happens the endometrium appears nice and thick, but the uterus is short. In these cases, the endometrial volume may not be sufficient. A minimum endometrial volume of 2.5 to 3 cc is required for good implantation. And that is why, in some cases now, instead of talking about the endometrial thickness, we are talking about the endometrial volume, and this can be done by 3D. Of course, just like the 2D, the 3D vascular parameters for the endometrium are also important. Studies have shown endometrial and subendometrial flow by 3D power Doppler may be useful in prediction of endometrial receptivity and pregnancy rate of IVF cycles. But this is of more important when we don't have a when we are not sure about the embryo quality. Remember that when the embryos are very good, even a poor endometrium, you may have a conception. But when you are not sure about the embryo quality, and that especially happens in your IUI cycles, you are not sure what is going to go to implant. And in those cases, it is very essential that you must always assess the endometrial vascularity along with its thickness. So minimum 6 millimeter, preferably 8 to 10, vascularity reaching zone 3-4, RI less than 0.6, and PSV more than uterine artery PI less than 3.2. There are 2-3 points which are important and which correlates to what your talk. So that I want to repeat. I want to tell you that when we are talking about ovulation, IUI done at any time doesn't make a difference in the pregnancy rates. I don't disagree with that, but that is when you have not checked the Dopplers. When you check the Dopplers, that's when you are more precisely evaluating the quality and the timing of the IUI that you should select. There are two things, therefore, I want to talk about here, and one is about decision on the trigger agent, and one is how many IUIs, and that's where I will end. Please forgive me for that extra time, really. So when we all know that we do not want to give HCG as a trigger, or we don't even want to give HCG as a dual trigger when there are multiple follicles, when the estrogen levels are high. It is your Sono ADC which can help you find out how many follicles totally are larger than 11 millimeter and in your IVF cycles, or how many follicles are there between 11 and 14 millimeter in your IUI cycle, apart from the mature follicles, and that will tell you whether to give HCG as a dual trigger or not. If there are more number of medium-sized follicles, it is these follicles which are responsible, which are culprit for the development of OHSS, and therefore pre-trigger Sono ADC is important. The second important thing is the vascularity. I told you that the PSV of the follicle correlates with the LH levels. As the LH level rises, the PSV of the follicle increases. It reaches as high as 45 centimeters per second an hour before the rupture. And therefore, if you are doing a pre-ovulatory scan and if you see that the RI is low but the PSV of the follicle is higher, that means you are not 36 to 42 hours away from the that point. So the ovulation is going to occur earlier. And in these cases, if you plan an earlier IUI, the chances of conception are very good. This is again a new concept, but I will not be able to discuss it all in detail. If at all time permits, sometime we will discuss that again. Apart from that, sometimes the question, and that is one last question which I will want to touch, that is about the pre-transfer or pre-trigger progesterone levels. That 1.5 nanogram has created such a havoc, but again we have to remember that is an immunological level. You have to find its effect on the endometrium, and remember that actually the progesterone level starts rising even before the ovulation occurs, soon after the surge starts. That means that progesterone is going to show its effect on the endometrium, and that appears like a fluffy outer margin of the endometrium. If you remember the grade A endometrium sharp pencil line, this is fluffy, like you have drawn with a highlighter. This tells you there is a physiological and a short duration exposure of progesterone to the endometrium. But the moment the outer margin of the endometrium starts becoming hyperechoic, after that you should not start. So whatever the blood level, you can check the blood level, not a problem. But the actual thing is what is its effect on the endometrium, which is going to affect the implantation. And that is why these signs are important. There's lot to talk, cannot end, but I will have to conclude the session. And I know you all may be also tired. I've talked for 46 minutes, right? So, but remember that it is Doppler, which is very important. Ultrasound is a very important monitoring modality. And as Dr. Durga has said, I again repeat, do it yourself when you are monitoring your cycles. That is what will improve your pregnancy rates. Please don't send to people. Thank you very much.
Thank you, madam. We are indeed deeply impressed with the depth of your knowledge and the way you have been teaching us, in depth this very complicated topic. Thank you very much. We are indeed greatly privileged to hear this talk. And thank you once again to Dr. Nilesh, Dr. Durga for this opportunity. And I urge all of you to see Dr. Nilesh Center. I have been there. It's really a state of an art institute. So congratulations again.
Though we have not really seen the center, after today's lectures, I'm very confident in referring all my patients to the Oasis Fertility.
Thank you, ma'am, for mentoring us today on ultrasound and infertility. I would like to request Dr. Nilesh Balkaude and Dr. Durga Rao to please felicitate Dr. Sonal Panchal as well as our chairpersons.
Can we have a huge round of applause for Sonal Panchal, ma'am? She is a international faculty for ultrasound, and with single phone call, she accepted to come here. And she always travels throughout the night, so she's been awake throughout the night and covering tea here in the wee hours, morning hours of today. And still we can see the energy in her to give a 45 minutes non-stop lecture on ultrasound. Thank you, ma'am. Hats off to you. I have been very fortunate to learn under her at Nagore Institute, the ultrasound in infertility. You can also take the privilege. Thank you.
Yeah.
I request Dr. Nilesh Balkaude to kindly felicitate our chairpersons. I request Dr. Durga Rao to felicitate Dr. Rajeshwari Pawar. Thank you, ma'am. Thank you, sir. Before we start our next session, I would like to request our delegates to please download the Kahoot app for the delegate quiz. We'll also be serving refreshments inside the conference hall itself. For our next scientific session, I would like to invite on stage our chairpersons, Dr. Madhuri Laha and Dr. Archana Kankal. Dr. Madhuri Laha is a consultant at Motherhood Hospital. She's a former consultant at Columbia Asia Hospital Pune and Apollo Hospital Bilaspur. She's been a secretary for Foxy Bilaspur. Dr. Archana Kankal is a consultant at Kankal Clinic. She's a former consultant at Valvalkar Hospital and panel consultant at Inlak Budrani Noble Hospital and Columbia Asia Hospital. I request Dr. Madhuri Laha to please introduce our next speaker, Dr. Krishna Chaitanya sir.
Um, I welcome Dr. Krishna Chaitanya M. I will say if this is a movie, infertility, embryologist, what I personally feel is a director of a movie. Hero may be anyone, but if director is not good, obviously movie will definitely flop. So I'm really enjoying this because I'm chairing a session where embryologist is a speaker. So Dr. Krishna Chaitanya, he is a scientific head and clinical embryologist at Oasis Fertility. He is expert in clinical embryology, studied and practiced in Australia. So see, he has a enriched experience at Australia also. He is passionate about the human embryology and constantly research on innovative approaches to improve the success rate of IVF treatment. I welcome Dr. Krishna Chaitanya and looking forward for his lecture. Thank you, sir.
Thank you for that kind introduction, madam. So I think coming to Pune is always special, and with my team yesterday, I was trying to learn a bit of Marathi. I know the two words that they taught me last night, God, God, Chan, Chan, and that's what it feels like to be here with you all today. To see a full hall is an absolute God, God feeling that I have. So I think there's a lot of theory. I saw a lot of people taking notes. So I'm going to give you a bit of relaxation. There's not much of notes that you're going to take, but I'm going to take you into a little fun learning. I think 1978 there was a lot of fiction. You know, we said, okay, can we design a baby? And now in 2022, yes, we can. So I know technology has grown in various directions, and we in India can do all of this. I'm the right example to tell you all that we at India are proud to do what the Western countries do. I was in Australia. I was fortunate to be at Monash, where I've really met the stalwarts. You know, I went to learn the best technology. I did learn it. I came back to India thinking I might not fit in the Indian fertility industry, but I was wrong. And if I were not to come back, I would not have got this platform of voices. I think we do a wonderful job. I think we've started publishing. We see a lot of youngsters doing it. I think we got to do more and more of that. And that's what is going to take India and the global map high up, because we've got fantastic clinical team and embryologists in the country. And this is just a glimpse of what the country has achieved over the years on this platform of voices. So I think 4 decades, there's so much that has happened. There's a point where we thought, okay, if IVF doesn't work, donor is the way of treatment. And in the last few years, we have found a lot of newer methods of giving a couple a self-gamete conception. And all these new advances are more focused on enhancing the success where a self-gamete conception is possible with minimal donor involvement in treatment. And with the ART bill coming up, where donors getting a lot more difficult, I think these newer advanced methods are going to take an upper hand. So let's just look at the latest trends that have evolved with the ovary, with the sperm and testis, and the embryo and the laboratory. So while talking with the ovary and the egg, I think oncofertility has been a latest advancement, and that's really been a ray of hope for a lot of cancer surviving patients. I think there was a point where saving the life was important, but now I think these cancer survivors are looking forward to have their own family, and it's their basic right. And there is a technology which we all can apply, and that's cryopreserving the ovarian tissue, cryopreserving the oocytes, a simple thing of making aware your patients that there is something that you can do is going to take them a long way. And I think at Oasis, we've been instrumental in getting this program. One of the pioneers in getting fertility preservation across to the Indian fraternity. And these are the actual numbers that we have been doing with men and women in reproductive age who've approached us, got some kind of fertility preservation, and at least 30% of them have come back and had treatments and a successful family. So that's a little glimpse, and helping you all make aware that fertility preservation is now a routine clinical practice. Even ASRM has given a statement in 2021 that ovarian tissue also is something that is a routine clinical process and no longer experimental. And that's the review committee, which said that oocyte cryopreservation is also a routine practice and no longer experimental. So that's been our experience at Oasis, where even with frozen oocytes, we've had on par success rate with what the SART website claims. So oocyte vitrification, where both the donor oocytes and self oocytes can be vitrified, and we can give them a comfortable fertility journey. In vitro maturation, that's something that's very, very close to me and Dr. Durga. Dr. Durga, while she was at the McGill University, she was, in fact, one of the first to publish a paper in Nature way back where there was success with in vitro maturation. But again, after years went, I think the success was not great and people didn't really want to do it. So this year, COVID time, we did have a collaboration with Brussels University where we're working on a newer way of doing IVM where there's no HCG. There's absolutely no use of gonadotropins. You're going to take 6, 8, or 9 millimeter follicles out. You're going to do an in vitro maturation with something called as a biphasic media. And currently, we are collaborating with the Brussels people. And in fact, we are proud to announce in this meeting that we had the first pregnancy done with this new protocol. And we are hoping this is going to change the way we are going to practice ART. We all know gonadotropins is something that's causing a lot of discomfort to the woman, a lot of side effects. Even from the expenditure wise, that's something that's not letting a lot of women come forward to take it. Probably in vitro maturation is the answer. And the only reason why IVM, though it's been there for the last 3 decades at least, the reason has been the cost and the side effects, and hoping that IVM is going to address this with this new research that Brussels is doing. That was a little bit about the ovary and the egg. So IVM and oncofertility, which is fertility preservation, are the 2 latest things, and absolutely doable and not experimental at all. Looking at the human spermatozoa, what are the latest things that we're doing? I think there's so much of research going on with sperm DNA fragmentation index. There's so much of confusion added at times. Too much of knowledge is also difficult at times. So I think there is a group of people who say, get a DFI done with every basic semen analysis. Every time a man comes in, get a sperm DNA fragmentation. Honestly, I don't think that's still an acceptable consensus. Be it SRM or SRA are still not recommended. We do not know if the routine use of DFI is still a valid thing. But having said that, what is clear at this point? DNA fragmentation is detrimental for ART outcome. It's proved beyond point. There's 2 SWOT analysis and meta-analysis have come on that. So it is detrimental. Your embryo development gets affected, your implantation gets affected. A recurrent pregnancy loss is possible. Now, there's so much that we do with the female thing. If you're seeing 2 miscarriages, which is idiopathic, time to get a sperm DNA fragmentation done. And if you're doing ART with this fragmented DNA, you've got a wonderful answer, ICSI. Something goes wrong, just do ICSI, that's going to solve a problem. I, as an embryologist, strongly disagree with the concept that ICSI is the answer for male factor infertility. In fact, that's the last thing to be touched upon. And there's so much more that we could do involving the man, because there's a potential risk of epigenetic changes. The worst is yet to come. We're still not seeing the worst. We're only seeing the good side of it. The bad side is probably yet to come if we do not get more conscious and responsible with what we're trying to do at this point. So it's detrimental, but we do not know how to handle this. So there's a lot of research that's gone in. A simple gradient technique, what we're doing itself could probably help you get sperms with good DNA. But again, we're still waiting for this. Max and microfluidics of this entire plethora of things have been in the limelight in the recent times. And Oasis has had a lot of publications on Max and microfluidics. Fantastic technology. I'm not advocating anything here. Easy. The best advantage of Max and microfluidics is you can do an IUI. You're getting sperms with good DNA quality. In fact, at this essay, we had a total of 9 abstracts that got accepted, of which 3 posters are on max and microfluidics. We have tried comparing the efficacy of max over microfluidics. Both equally seem to give the best reproductive outcomes, and we've looked up to the live birth rates. But these are the various options that you could consider when you're handling a couple with raised sperm DNA fragmentation. So there's another thing that we know teaser has been done for azoospermia, but a newer indication is to do it when there's raised sperm DNA fragmentation index. What you can do with the man when there's raised DNA fragmentation. One of the options is to do a testicular sperm aspiration. The funda is you're going to the seminiferous tubules where the whole oxidative stress is not taking upper hand, because it's the epididymis where the maximum damage that's happening. So do a TISA as an answer, but it's still not proven. So that's 10 years data published in Fertility Sterility, where we did show that the implantation was better with testicular sperm. For a very long time, even I have said this in the beginning that, severe male factor, that too with a testicular sperm. As an embryologist, I used to be scared to do those cases. I didn't know what the fertilization would be, what the reproductive outcomes would be. But over the years, doing it the right way, if you've learned the right laboratory technique of handling your testicular sperm, I'm sure ejaculated sperm or testicular sperm are going to give you on par success rates, and that's 10 years OASIS data published in Fertility Sterility. And again, we published where we compared the outcomes just with ejaculated and testicular sperm, and we did have a comparable outcomes of implantation and live birth rate with the ejaculated sperm, and there's no statistical difference that we saw. We also looked at the paternal and perinatal and neonatal outcomes, and again, we didn't see any difference with testicular sperm. And why am I focusing on that? We are strong with our thought process that testicular sperm is going to bring some kind of abnormality. The answer is no, and here's the Indian evidence done at OASIS, where I think with testicular sperm, we do have safer outcomes. You just have to learn it the right way. And I think we still have this myth that IVF conceptions, we could end up with a higher incidence of abnormalities, congenital anomalies, be it the scientific fraternity, medical fraternity, or the patient fraternity. This is something that is worrying a lot of us. And this is way back in 2012, where they've put across the statistics that there's a 9% incidence of having anomalies in IVF conception, but it's 6.6 in natural conception. There's absolutely no statistical significance. I think evidence is what we've got to talk with our patients. Just trying to tell that I'll do wonders. I think it's Google days. People know it better. They do a lot of research when they come to us. So I don't think the unfortunate thing about our generation, we can't fool our patients anymore. I'm sorry. It's just trying to keep everybody's in a lighter mode there. But the fact, IVF conception versus natural conception, we're not dealing with something that's abnormal or alarming at this point in time. We really don't know what's going to happen. And this is where publishing is so important. Fresh versus frozen, whether it's testicular sperm or the frozen ejaculate. Again, there's a concept where people say, oh, frozen sperm or egg or embryo, it's not going to give you the best outcome. Again, that's why we did this study. Again, it was a 7 years data that we published. In fact, it is one of the Pune embryologist Sakshi who did this wonderful research work and presented and got it published in Fertility Sterility. We found no difference in live birth whether it was fresh or frozen testicular tissue. So the take-home message from this, if you're planning for a TISA for an azoospermic man, you need to contact an embryology lab and ensure the testicular tissue is frozen if you've got sperms. Trying to do a trial TISA and the histopathology saying they're sperm, and then you send them to an IVF center where we need to redo the surgical sperm retrieval. It's unnecessary intervention to the man. Fresh or frozen TISA, the outcomes are the same, and we routinely do this. In fact, when time permits, we just do a TISA, we freeze. 90% of our TISA XCs that happen at OASIS are with frozen testicular sample. And trust me, there's been a 1% incidence of repeating the TISA on the day of OPU. And then with micro TC coming in picture, I think we have found a way of doing a lot of freezing with testicular sperm. So this published in at SRM, it was accepted and published in Fertility again, where we showed that microfluidics seems to be giving a better implantation and clinical pregnancy rates, especially in people with failed implantations. And so did we have a good outcome with Max, which was accepted at ESHRE in 2019. And this was again published in Human Reproduction, where we showed that Max is an efficient way of handling sperm DNA fragmentation and optimizing reproductive outcomes. So that was a little advancements with the sperm. I think teaser, the testicular sperm seem to be giving an on-par success with ejaculate sperm. Fresh or frozen tissue should not matter much. There are newer ways of selecting sperms with good DNA quality, because DNA fragmented is a detrimental thing. Max and microfluidics is in the limelight. Oasis currently is doing an RC daily ejaculation, max microfluidics. I think we're waiting for publishing our data because it's still an ongoing study. So coming to the embryology lab, I think there's multiple factors which are going to decide the success. It's not putting back 5 or 6 embryos or just having the senior most embryologist. It is a pyramid of things, right from your air quality, your equipment, your incubators, your culture media, and what's more important is quality management system. We sometimes fail to give a lot of importance to quality control. Quality control, honestly, is a routine work. For me, quality is like what my mother did in the kitchen. That's how I teach all my students. Quality control, imagine your mother. Over the years, irrespective of what their educational background was, I think it's never happened where she's given us reasons of not giving breakfast. It's the planning that she puts in, and the taste never changes. I'm sure we all have this little taste in our mind registered, and that's mother's dish, and that's what is quality. You got to keep doing it again and again. You got to learn it, and unless you have that secret quality recipe, your dish of embryo is never going to come up the right way. So there's so much of science and research that's gone in to pick the best embryo, because we all believe that a singleton pregnancy is what we want. We want the best implantation from an embryo, a singleton pregnancy with uneven full ANC. All the obstetrician must be hating a lot of us for creating a lot of multiple gestations, and we don't have night duties, thankfully, so we sleep very peacefully at home. So how do I ensure that I help the fraternity of obstetrics is to put back one single embryo. And there's so much of science that's developed, right from a blastocyst culture, a low oxygen culture, a time lapse, which is helping us. PGTA per se helps us pick a single embryo. Because at the end of the day, whichever embryo you pick, you've got to know that it's got the best implantation. And there are these various options that scientists have tried and seem to be working in real time. I think we are all moving towards doing artificial intelligence. I think that's where we are heading. And Oasis is now doing a collaborative research work with Monash University, where we've given our 10 years data, and we're trying to see what are those parameters which help us predict at a gamete level, at the fertilization level, where we could do a deselection or selection and end up putting one embryo, and probably help counsel the patients of how we could go ahead and put only one embryo back. It's all how we counsel them, because every patient wants to finish it in the first attempt. It's a cool thing to have a twins, unless they end up in the NICU or an obstetric ICU with a lot of complications. They don't really know what they're doing. So as medical practitioners, I think it's our moral responsibility to counsel them for a single embryo transfer, and things like artificial intelligence are going to really help us go a long way. A few other things, fresh or frozen embryo transfer, beyond doubt, I think right now it doesn't really make a difference, but frozen embryos still seem to be offering on-par success rates, but it doesn't hamper the implantation. What's more important to understand that a frozen embryo will not give you lesser pregnancy. In fact, it gives you on-par or even a better pregnancy outcome, because you are manipulating, or you can control the uterine environment, the hormonal milieu in a better way in a frozen embryo replacement cycle. You can avoid OHSs. I think that is the biggest advantage which has helped us become of OHSS free clinic, is a freeze-all strategy. where you could just freeze everything, not put back and sit back and relax and not have OHSs there. So that's been Oasis success, where with frozen embryo transfer, we've had the best success, cleavage or blastocyst, day 3 or day 5. I think beyond doubt, it's proven day 5 is the best. There are times where people have said, you know what, your pregnancy rates, it's a friendly discussion with my colleagues. They say, I'll take home baby rate, Oasis versus my clinic is hardly a 5% different. Why are you really going gaga with blastocyst culture? I think I've given a quality in my treatment where I've put back a single embryo. We also used to do a cleavage transfer with 3 embryos in the first or second year. Our statistics in 2011 to 2022, our triplets have become less than 1%. Our twinning has come down to 12%. Earlier, it used to be close to 30%, where we're putting 3 embryos back. So I think that is where we've made a difference. Probably the take-home baby rates still remain the same. The literature says blastocyst is the best way of doing it, and so do we believe in. Putting on 1 or 2, I think 1 is the best. How many is too many? There's no answer for that. And putting too many is not going to improve your take-home baby rates and pregnancies. It's only adding a lot of stress. So is your lab equipped enough to handle the embryos till blastocyst? Is your embryology team trained enough to pick the best embryos? Are you a good counselor who can convince your patient to get 1 embryo transferred? I think that's where the whole game is. It's nothing to do with how the embryos are. We spoke a lot about PGTA, but PGTA is another thing that we have been trying for failed implantations and recurrent pregnancy losses. And again, we seem to have had, the way we look at it, though the STAR trial said that PGTA doesn't really improve take-home baby rates, but these are recurrent implantation failure people who've had at least 2 embryo transfers with 4 blastocysts transferred, no pregnancy. So in such people, doing a PGTA, 58% of them went home with a child. Of those people who didn't have a pregnancy in the first 2 IVF cycles. So that is where PGTA has made a difference. And I think we do believe in doing embryo biopsy and PGTA for this RIF and RPLP patients. Doing a routine laser-assisted hatching, that's another technology that's come up in the field. Our experience, doing it for everyone doesn't make a difference. Google Babas, they come and say, oh, your clinic doesn't have laser, then I'm not getting the treatment done here. It's sometimes made sound that we're criminal not offering laser-assisted hatching. There goes the literature. A routine laser-assisted hatching just before a transfer has not improved implantation rates or take-home baby rates, even in advanced maternal age women. So that's again our RIF data with PGT and RPL data, where again, women who were having recurrent miscarriages, first trimester ones, by putting a euploid embryo after PGT, 58% of women went home with a live child. This is right now gone for publication with RBM Online. We again had done PGTA for women 37 and above. Control group, no PGTA, and PGTA done, and we found that PGTA actually gave the best implantation and take-home baby rates. So women 38 and above, to save and reduce the time to pregnancy, I think PGTA is going to really make a difference. So over the years, where PGTA is making a difference, it's making a difference to shorten the time to pregnancy. The Z generation wants everything fast. They're going to have contraception for 10 years, they come back, and the next month their UPT should be positive. She's 38, she's 40. Is that possible? We can shorten and do that. PGTA is one such technology which probably is going to help, and that's our data that's gone for publication with RBM Online. So is salt, sugar, the goat's recipe, is that the secret? There's so many ingredients that go into that, and quality is the base. If you do not have quality and you're adding a lot of flavors, it's not going to give you the best outcome. So I think embryology, the whole lab work, is nothing less than a tapasya. I think you got to be concentrated. You got to keep on doing the same thing again and again, because there's a lot of failure and very less success. But you got to motivate yourself, and you've got machines all along there, and they don't talk. And if you can talk to these machines, I think the job is done. And that's where innovation and technology comes into the picture. I've married a techie, and I've always hated her because she had this weekend works. She said, I can work from home. And she had this weekend off. And as an embryologist, I have to work all 7 days a week. And Dr. Durga never gives me a work from home option. And that's where technology, there's an innovation that's helping us, and that's time lapse and artificial intelligence. And I also have a way of now working from home. And COVID, I think, created a lot more such opportunities thanks to Zoom and other platforms. But yes, I think we are at the forefront of technology at Oasis. We do a lot of innovations. Artis is one of this. It's an electron medical record system. 25 centers. All my colleagues ask me, how do you get some peace? Do you really have a family? And how do you really balance and control all of these centers? It's this platform. This is cloud-based. Everybody is putting information. I'm sitting at my home with my laptop, and I can actually see what's happening in all my laboratories, help them troubleshoot, and give them the directive that they expected. Electron witnessing system. I think it was launched, and that is when, thanks to Bollywood, the Good News movie came. It really worked out very well for us. When people said, okay, is there going to be a good news in a wrong sense at your clinic? We said, we have the EWS, the electron witnessing system, and you be rest assured. So the EWS, the electron witnessing system, will actually capture the movement of your eggs and sperms at every step. And it's so robust that we can take a printout and give the patient that look at every point your sample was witnessed. And we have done our best from the technology side to ensure that your gametes were not mixed. So technology is something that we love having at Oasis. We've got a very strong IT team which helps us do it. And that's how we've amalgamated technology innovation with embryology. So thank you. Those were the emerging trends that have kind of made lives of embryologists easy. But I think it's a lot more fun to do embryology now than what probably it was in the early 2000s or late 90s. So welcome to the era of technology. You just need to have the right intent. Everything is possible, and success is something that we can keep on increasing with these technologies. Thank you so much, everybody.
Thank you, Dr. Krishna. It was a really wonderful session. We understood at Oasis it is not to overdo. At the same time, intelligence, you're using artificial intelligence, which is helping. And it gives when you're saying that one is good, it really eases our life as an obstetrician. One, when it was triplets and four and reduction, that job is done now. I'm seeing most of IVF centers are going for one single embryo transfer, which is really good for us as obstetrician. It is good for patients also, obviously, because they are getting the good results, and take home baby rate is really good. Thanks a lot.
Thank you so much.
Thank you, sir, for that informative talk. I would like to request our chairpersons to please felicitate and thank Dr. Krishna Chaitanya, sir, for his talk. Thank you, sir. Our next talk is on IUI, how to optimize success. I request Dr. Archana Conclave to please introduce us to the next speaker, Dr. Nilesh Balkaude.
In the beginning, I would like to thank Dr. Nilesh for giving me this opportunity. Thank you very much, sir, for inviting me here. Dr. Nilesh doesn't need any introduction at all. We all know that he's the hero of today's film by Oasis. This Oasis is the well-managed, very nice infertility center wherein patients are catered to very nicely, and all doctors who are referring or doing their cases there are getting excellent results. Dr. Nilesh has a decade-long distinctive experience and expertise in this field of infertility, reproductive medicine, and gynae endoscopy. He has done more than 1,200 cases of operative laparoscopies and around 3,000 cases of diagnostic and operative hysteroscopic myomectomies as well. Articles also that he has indexed many articles in national and international journals. Dr. Nilesh, thanks.
Thank you for your kind words, ma'am. Although I'm the hero, we all know that there's a huge team running behind all of us, and we definitely have all these results coming up only because of the team. And I thank my all team for this Art Conclave organization as well. Today, I'm going to be very crisp when it comes to tips and tricks of IUI, because we are already late by around half an hour for the session, and we have yet a panel to go, which is a very interesting panel. So I don't want to lose on the time of panel. So we'll have some take-home messages, crisp messages regarding the tips and tricks of IUI. We all know knowledge is power, but knowledge is not just power, it's a potential power, and action is power. So acting on the knowledge is very important, and that's why this is our learning objectives for today. Appropriate case selection, following good ovulation induction strategies, role of ultrasound and Doppler. We have already seen Sonal Madam talking on it, but the IUI perspective about the role of Doppler and timings of IUI, do they make a difference? Role of endometrium, male factor and IUI, lots to learn in IUI as well. We'll just go briskly on this. Which patient will benefit the most with IUI treatment? I'm not waiting for the answer because we don't have time. It's answer B, sperm dysfunctions. More than anything else, IUI is the simplest and least expensive form of ART treatment. Once we want to go for an advanced treatment option than a natural cycle, it fills the rift between a natural cycle and the IVF. First and foremost thing which we need to counsel our patients when it's going to be IUI is what's the success rate, because everybody is talking about the success rate. Patient comes with the expectation to me that the first IUI cycle will be successful. That's not the case. We need to talk about the success rates. We need to tell the patient it depends upon the ovulation induction strategy and carefully planned approach. Then only we'll be able to give you a success rate per cycle of around 18 to 20%. So this counseling has to go. You have to tell the patient that the cumulative success rate is important, and therefore 3 or 4 cycles of IUI may have to be done in a case of unexplained infertility. Sometimes even more number of cycles for cases of ovulatory dysfunction, or in cases of sexual dysfunctions where we are justified to do more number of cycles of IUI than going for IVF. Not working? Yeah. So these are the advantages of IUI. First case scenario. Patient of infertility, married since 3 years, no major factor except a 2 by 2 centimeter endometrioma, not operated, and comes to you with the HSG report with bilateral free spill, already has undergone ovulation induction cycle. What's the plan of your treatment with no male factor? Male factor is normal. So what do you do for this patient? Definitely will proceed ahead with IUI. Why? Because as we know, 2 by 2 centimeter endometrioma goes into level or grade 3 endometriosis. Any endometrioma in the ovary goes into grade 3 endometriosis. Grade 1 and 2 is where we are going to wait and see and observe, do expectant management, do ovulation induction. But whenever it is grade 3, the time is ticking because the follicle quality is going to get affected in the time being, and also the follicle number is going to get affected. So a planned approach for these patients, 2 by 2 centimeter endometrioma, you may or may not operate. If it's a larger size endometrioma, you might think of operating, but always do a preoperative AMH levels of these patients and be conservative when you are operating an endometrioma so that you don't lose on the ovarian reserve later on. So these patients are where we can do IUI, female factors, male factors, not going into the details of all this. Baseline workup is must when you are starting IUI. 3 important tests. One is ovarian reserve testing. Too low reserve, you need to have a plan how many number of IUI cycles. Sperm dysfunctions, like semen analysis forms another important aspect of starting the baseline workup. So if you have total motile sperm count which is less than 10 million or incident IMSC which is less than 5 million, your results of IUI are going to be poor, and this counseling needs to be done. Even if the patient is not affording, this patient might require IVF eventually. So just counsel the patient regarding the count motility parameters. And third and most important test before doing any IUI, it is justified to do a tubal patency and then only go ahead. Tubal patency can be done in a non-invasive or minimally invasive methods these days. It's not necessary to do a diagnostic hysterolaparoscopy for each and every patient. That's the message which I want to give on this platform, that even a simple HSG, and if you want to do a SSG, saline sonography, that is also good. I personally prefer to do a saline sonography under anesthesia because many patients of HSG we get a corneal block and we get a false positivity of tubal blockade. That can be gone if you're doing a good proper saline sonography under anesthesia. There is no corneal block and you can properly evaluate the tubes. Along with the tubes, you can evaluate the uterine cavity as well by putting the saline inside the cavity and looking for any small polyps or fibroids. These are the probable contraindications for IUI, not going into the details. These are the steps. Selection and counseling, ovarian stimulation, monitoring the follicular growth, timing of IUI, sperm preparation techniques, and then the insemination. How many number of IUIs we can try depends upon patient to patient, but for unexplained infertility, we need to be on the lower threshold, that is 3 to 4. How many number of follicles we target? The answer is not more than 2, according to the SRA and ASRM guidelines. At my center, we are doing a 2 to 3 follicles, what we are targeting. Anything more than 3, it's high risk for multiple gestation, and we are not doing and going ahead with an IUI. How many cycles of IUI we can try? This is how we can counsel the patients. After the 4th cycle, the success rate is going to drop down, and therefore we can limit our number of IUI cycles. How many number of follicles? As I told you, not more than 2 or 3. Counseling is again an important aspect which we talked about. The success rate will increase when the follicle number is up to 2 or 3. Success will plateau after that, so we don't aim more than 4 follicles. So this is what I told. According to my experience, 2 to 3 follicles of 18 to 19 millimeters, that what I would target. No routine estrogen levels are indicated in IUI cycle. The size parameters are important, but as Sonal Madam told, I'm following her protocol of checking the perifollicular blood flow and then triggering the patient so that to optimize our IUI success rate. So it is not always only the size, it's always the functionality of the follicle. Regimen of choice. We heard from Durga Madam and Sonal Madam that natural cycle ovulation or natural cycle IUI is not recommended. Only ovulation induction treatment is not recommended. Then what is recommended is controlled ovarian hyperstimulation or COH with IUI is what is recommended. And this can be done either with CC letrozole or with HMG. I'm not going to this question. These are the success protocols which we need to discuss with the patient. Natural cycle IUI has got a very less success rate as against the best success rate with gonadotropin cycles. If we want to decrease the cost and also to optimize our results and to maintain our follicle number to 2 or 3, a combination of CC with gonadotropins can be used. However, if you see the literature of SRA and ASRM, they don't recommend the combination. But I think this is a tweak which we do in our Indian setups, and yeah, definitely can be useful for those patients. So we all know that the pregnancy rates are very high with gonadotropin cycles. The follicular genesis, we all know that there will be a rise in FSH, LH, and estrogen receptors, and the dominant follicles will start forming. And this can be assessed even by ultrasound. No need to do the test. We all know the follicular wave theory, where we need to stimulate the ovaries only where it doesn't cross the threshold, so that we don't have multiple number of follicles. So during this threshold, we need to give this ovulation induction agents. If we see IVF cycles, this wave doesn't come down. The bigger wave which you are seeing, it doesn't come down, it goes ahead. So we have hyperstimulations in those patients. This is what I'm talking about. So in a cycle, we need to stay in the window, and so that we have only 2 or 3 follicles. Individualizing treatment protocols is very, very important. Now, friends, when it comes to normal responders or low responders, these patients, we can use gonadotropins and stimulation agents to make follicles around 2 to 3. But whenever it comes to PCOS, our target may not be a multifollicular development. We should target a monofollicular development, because it's very difficult to maintain a 2 follicular or 3 follicular development and avoid OHSS. So once you have land up in more than 4 or 5 follicles, you are left with no option than to cancel the cycle. Triggering with HCG, if the follicle number is high and you don't want to cancel the cycle, agonist triggers can be used. Urinary versus recombinant HCG doesn't make much of a difference. Same is the case with gonadotropins, doesn't make much of a difference. Second case scenario is a case of PCO. The ovulation induction cycles have failed. Laparoscopic ovarian drilling was done. Chromoperturbation was positive. Next plan, what to do about these patients. These patients have the maximum chances of conception in the next 6 months because you have done the LOD for these patients. LOD is a justified form of treatment, but it can be used for those patients who don't want to gonadotropin IUI stimulation. So in a PCO patient, the first strategy is ovulation induction. Second strategy, if it fails, is either gonadotropin IUI or a laparoscopy, and the third strategy is IVF. So now here, the laparoscopy has failed. We can go for a gonadotropin stimulation cycle. This is the phenotypes of PCO, where the phenotype A is the obese PCO, hyperandrogenism, oligomenorrhea, and PCO morphology can all be used to diagnose this PCO. Lifestyle management is important before you start any treatment, so this has to be advised to the patient before you go for IUI. Ovarian stimulation rationale here is to keep the follicle number to minimum and achieve a monofollicular development. Drugs recommended in PCO, whether to go for letrozole or clomiphene, whether to go for gonadotropin. N number of studies have been analyzed here, and it has been shown, even the recent 2018 PCO guidelines say that letrozole is much, much superior to clomiphene citrate when it comes to PCO stimulation, where you can achieve a monofollicular development. And if you want to increase the success rate, if the patient fails to respond to letrozole, you can add a gonadotropin on day 5 or 6 of the cycle. This won't cause a multifollicular development. Only the dominance will be established, and you can have a monofollicular development after adding the gonadotropin on day 5 or 6. When you compare CC with HMG or letrozole with HMG, again letrozole with HMG is better. This is how we manage resistant PCOS. You are going for IUI, patient fails to respond, and it is showing a clinical hyperandrogenism or a biochemical hyperandrogenism. You can use glucocorticoids only in this category of patients where you are suspecting hyperandrogenism or the DHEA levels are high. This is how you use it. You can use prednisolone or dexamethasone starting with your ovulation induction agents, 0.5 to 2 milligram daily, and you can continue and taper it off, and you can achieve good stimulations with this. Metformin again useful for obese PCO and all lean PCO. Lean PCOs also you have 25 to 30% incidence of insulin resistance where you can use metformin, especially metabolic syndromes, BMI more than 30. These can be used as adjuvants. The inositols still remain experimental therapy. So although they can be used, they cannot be used individually. You can have adjuvant role along with metformin. Melatonin, yes, can be recommended. LOD, as I talked of, is only for those patients who don't want a close follow-up. Only thing is we don't want to do this. So this is the picture which is shown that we don't want to do this. We have to follow the rule of 4. 4 punctures, 4 millimeter depth and 40 watt current. That's the maximum we need to do. If we are going for LOD, we will not go into the mechanism of action of laparoscopic ovarian drilling. Unexplained infertility, again, letrozole is better. 3 to 4 cycles is what we do in unexplained infertility. This is the Foxy TOG recommendations in 2017. If the age is less than 35, we go for timed intercourse, 3 to 6 cycles, and controlled ovarian stimulation with IUI for 3 to 6 months. If it fails, we go for IVF. If the age is more than 35, we avoid the timed intercourse cycles and directly can go to the IUI cycles. This is a case of male subfertility. And how do we do an optimal IUI stimulation? So single follicle in cases of PCO or irregular cycles, or 2 to 3 follicles for regularly menstruating women. Ultrasound, already we have gone through, not going into the details, but the color Doppler assessment of the ultrasound forms an important aspect of improving or optimizing your IUI success rates. So a day 2 scan is very, very important. We need to assess whether the patient is zomo-responder or hyper-responder, accordingly give her medications. As madam told, even for IUI cycle or IVF cycle, if you have a residual cyst and it is not functional, by putting in a Doppler, if you see that the cyst is not functional, you can go ahead with the cycle. May it be IUI or may it be IVF. If it is a functional cyst, you can give OC pills for that patient and go for the stimulation next cycle. The ideal size of follicle which we aim for is between 18 to 22 for a letrozole or gonadotropin cycle, little higher for a CC cycle. Why timing of IUI is important? So sperm's survival, as we all know, is for 2 to 3 days. but maximum oocyte fertilizing capacity of the sperm is for just 12 to 24 hours. And it is maximum at 18 hours. So cryopreserved sperms, if you are doing a donor IUI, or if the husband's sperms have been cryopreserved and then you are doing IUI, their maximum action is for 12 hours. That's why timing the IUI is very, very important, and we are going to come to the timing, how we should when we should trigger and when we should do the IUI. It depends on the size of the follicle, depends upon the endometrial thickness. Size 18 to 22, endometrial thickness 8 millimeter, but it doesn't stop there. We also do the endometrial blood flow assessment, give some medications if the blood flow is less, and we go for this slide. So here we assess the perifollicular blood flow, and if it is more than 2/3, the PSV of the follicles is more than 10 centimeter per second, the LH surge is going to start in next 26 to 29 hours. If the perifollicular blood flow, if the PSV of the follicles is more than 20 centimeter per second, there will be a rupture within the next 12 to 14 hours. So friends, I don't recommend a double IUI, but in patients where you know that the rupture is going to occur late night and the patient is going to come to you after 24 hours, these are the patients where probably you can plan a double IUI for such patients. So whenever you see that the flows are higher, then only in that case you can plan a double IUI. Otherwise, a single IUI can be beneficial. Any flows more than 20, probably you do IUI at that time, because next 12 to 24, 12 to 14 hours, it's going to rupture. Another important scenario is rising PSV and low RI. What we have seen is imminent of rupture, but a steadily decreasing PSV or rising RI, this indicates that the follicle is going into LUF. And these patients, we have to counsel that LUF can occur. And what are the causes of LUF? These are the causes. So we need to rule out all these causes prior also before we start the IUI. Hyperprolactinemia needs to be treated. Endometriosis, adhesions, these can all cause LUF. Sometimes there can be a true LUF where the ovarian cells can be a problem, where everything fails and the follicle just ceases to rupture. So I won't go into the details. How we can manage LUF? So you can delay the trigger sometimes, or give a trigger dependent upon your follicular blood flow. You'll have least likely you'll have LUFs. Dual trigger is what we can plan. Along with the HCG, you can use an agonist and trigger the patient to avoid LUF. GCSF can be used 24 hours to 48 hours prior to the routine trigger. Avoid NSAIDs. So tell your patients not to take over-the-counter drugs whenever they are taking any fertility treatment. May it be IUI or IVF, both NSAIDs are going to affect your results. And even if after all this the follicle doesn't rupture and we have persistent LUF in the subsequent cycles, IVF remains the option. Another case is thin endometrium. In IUI, thin endometrium can be a problem and it can decrease your success rates. How thin is thin? Probably 7 millimeters is what many of the studies mention, but we have seen results even at 6.5 also if the flows are good. So if the endometrial vascularity is good, the endometrium is good vascular, then the success rates can be very good. You can use agents such as aspirin, sildenafil, the nitric oxide donors, GCSF to improve your endometrial thickness in IUI. You need not start estrogen for these patients. Remember, if you feel that the patient had thin endometrium and you start estrogen on a day 2 or 3 and you expect a good endometrial thickness, remember your oocyte quality is going to get affected. Let the oocyte achieve the dominance, see for the dominance at 14-15 millimeter, then the follicle will start secreting estrogen. Wait for the endogenous estrogen to act. Even after that, you don't have the rise in endometrial thickness. Probably, Sonal madam won't agree with me that you can put some estrogen. Probably it is after that time you can think of putting some estrogen, not in a very high dose, because estrogen is going to suppress your FSH and therefore your follicular quality is going to go down. So you wait before starting estrogen for these patients. I'm not going into these. Sperm DNA fragmentations, whether to think of in an IUI patient, if you have multiple IUI failures, if you had a history of any miscarriages in the past, and if you feel that there is a male subfertility and the semen parameters are abnormal, probably these are the patients where you can think of doing a sperm DNA fragmentation index. Whenever you think of doing a sperm DNA fragmentation index, you should do it in a proper way. the sperm chromatin dispersion or the visualization by doing the staining is a very crude method. I feel it should be done by the SCSA technique, the sperm chromatin structured assay, or you by doing a tunnel assay. So do it with only the labs which we are doing with these assays, because these are the most standard techniques accepted worldwide to do the sperm DNA fragmentations. So the timing of insemination is again important. We have to complete our IUIs before 90 minutes. Double IUI I talked about. Role of immobilization, we have to keep the patient immobilized for around 10 to 15 minutes. That has been accepted in a number of studies. Luteal support is indicated, especially in letrozole cycles and gonadotrophin cycles, where the patient, where the endometrium can go a little bit out of phase. So therefore, a luteal phase support can be indicated for such patients. Endometrial scratch, no much role in IUI patients. Cervical mucus removing prior to IUI doesn't help much. Difficult IUI, how to overcome, again an important aspect. If you're not able to negotiate the cervix, always try to do the IUI with partially filled bladder so that you negotiate the antiversion. Smaller diameter curved catheter can be used. However, firm catheters and catheters with stellate can cause a false passage. I won't recommend any of you to do IUIs with that. Ultrasound guidance is very, very important. These patients where we are not able to negotiate, ultrasound will help you. One, if you don't have an ultrasound in your clinic, very important step you can do is just use a uterine sound. Uterine sound will definitely open up small adhesions, and this can also help you. Remember, friends, just go back to your ultrasounds, see the position of the uterus, see the versions and the flexions. If it is anteverted, anteflex, you need to maneuver accordingly. So if it is anteverted, anteflex, your hands and the speculum should go down before you introduce the catheter. So that's very important to overcome this. So IUI is a very cost-effective, safe strategy before an IVF is planned. We can carefully select patients to improve and optimize our IUI success rates. Thank you.
Thank you, Dr. Nilesh, for the informative and to the point presentation. I'm very sure this will help all of us in our day-to-day practice. Thanks a lot.
Thank you, sir, for your talk on IUI. I request Dr. Nilesh Balkaude, sir, to please felicitate our chairpersons, Dr. Madhuri and Dr. Archana. Thank you, sir. Thank you, ma'am. I hand over the next session of the delegate quiz to Dr. Saili Chauhan.
The Kahoot app on your mobile phones to play an interactive quiz, because the first three winners are going to receive an attractive prize. So please do play the quiz, take up the quiz, and it's going to be an easy quiz. Whatever you have learned since the morning, that's only going to be asked in the quiz. Nice.
So good evening, everyone. I'm Dr. Saili. And after such wonderful, engaging, and informative sessions, now it is time for you all to put your thinking caps on and win some exciting prizes. So I hope you all have downloaded the Kahoot app. If not so, kindly do it now. And after downloading, you will be given the game pin. Kindly put in that. So you all will be given a series of questions and you will be given 4 options for that. And you have to mark the right one. The one who answers correctly and the fastest will be leading on the scoreboard.
This is your game pin for today, 713584. So you have to log in with the game pin 713584 and enter with your name so that we know who is playing. If you have not downloaded the Kahoot app, you can go on to the Kahoot website www.kahoot.it and you can play directly in the Google. So if you don't have Kahoot app, go to www.kahoot.it. It's mentioned there, and again enter with your name and with your game pin. That is 713584.
Okay, so more main points scored in this quiz will be upon how fast you answer. So try to be the quickest.
We'll wait for another 2 minutes for everybody to log in and we'll be starting after that. Should we start? Everybody is ready?
So can we start?
So those who are still remaining to log in, please note the game pin. Even if you log in later, once we start, you can access the quiz. So the game pin is 713584. You can log in even after the game starts. Please don't lock the quiz room. You can directly start. Yeah. Please start.
Okay, so all the best, everyone. So the first question, you can see an image.
And we always thank MCure for the technical support.
Okay, so what is the indication for the use of the procedure below? Is it A, unexplained infertility? Is it B, recurrent implantation failure? Is it decreased ovarian reserve or thin endometrium? And your clock is ticking. So the right answer is recurrent implantation failure. We have 14 people answering that.
We'll see who has answered it quickest. We can immediately see on the screen. Next, please.
Yeah.
Next click. Yeah. So these are our first three.
First three.
First five. Next.
Next question. So next question will be how to differentiate and euthanize unruptured follicle from a corpus luteum. Is it perifollicular RI of the corpus luteum is 0.51 to 0.59? Is it perifollicular RI of LUF is 0.35 to 0.5? Is it an ecogenic endometrium with good endometrial flow in LUF? Or is it a PSP of 50 to 20 centimeter per second for the corpus luteum? Okay. So the answer is PSP of 15 to 20 centimeter per second. So now we have Monica leading the board right now. The next question is following are the features of a mature follicle except A is a rounded 16 to 18 mm follicle with thin wall and internal ecogenicity. B is cumulus oophore is present. Color Doppler vascularity seen surrounding 3/4 of the follicular circumference or an RI of 0.4 to 0.48. So our answer will be A. The next question. So, following the ASRM 2020 recommendation for treatment and unexplained infertility, it's recommended to use letrose with time intercourse, recommended to perform IUI and natural cycle, recommended to use letrose or CC plus gonadotropin, or recommended to undergo course of ovarian stimulation and IUI with oral. If unsuccessful, go for IVF rather than ovarian stimulation plus IUI with gonadotropin. Yeah, and your answer is going to be D. Okay, so those are the leaders right now. Next question is name the procedure used for selection of the sperms. Is it MAX, sperm BFI, microfluidics, or electrophoresis zeta? So your answer is MAX.
Max is magnetic assorted cell sorting, and for a high DFI, we can use that.
So following is not true about WHO 2020 semen parameters. That is sperm concentration 15 million, volume 1.4, progressive motility 30%, or viability 54%. Okay, so our answer will be a sperm concentration 15. Actually, the cutoff is 16 million. The next question. The best technique for DFI determination. Is it a tunnel assay? Is it SC assay, a comet assay, or a SCD? Okay, so your right answer is SC assay, that is sperm chromatin structural assay. Okay. So our next question. Name the procedure above. Is it ICSI, is it laser assisted hatching, PGTA, or polar body biopsy? So the answer is laser assisted hatching. Okay. So what is the above procedure used for? You can see an image above. Is it for morphological selection of the sperm? Is it sperm selection in raised DFR? Is it for selection of motile sperm or increasing the sperm concentration? Yeah, and your answer is sperm selection in raised DFI. This is the microfluidics that you are seeing. Okay, and our last question, what is the success with a natural cycle IUI? Is it 3 to 5%, 5 to 10%, 10 to 15, or 1 to 2%? Yes, and your answer is 3 to 5%.
We have the podium now with Dr. Pradnya, third position, Dr. Kanchan, second position with 4,000 points, and first position, 6,440 points, is Dr. Rajendra. Congratulations to the winners. Can you just stand up and please wave? Thank you for playing the quiz. Wonderful.
And well tried, all of you. Thank you.
I may invite now our panelists for the last session. We are going to be very crisp in this panel. Three important case-based discussions in infertility, clear the clutter and around the mind-boggling cases. So I welcome panelists on stage. Can we have the presentation? Dr. Kanchan Durukka, she is a consultant at Oasis Fertility. Welcome, Dr. Kanchan. Dr. Saili, she is consultant IVF specialist at Oasis Fertility, Kharadi. Dr. Deepshikha Dibivedi, she is a consultant fertility specialist at Baner and at Hinjewadi. Dr. Mugdha Joshi, she is a consultant obstetrician and fertility specialist at Bavdhan. Dr. Sambhida Dalvi, she is a fertility specialist at Wakad. Dr. Rashmi, she is a fellow and fertility specialist at Oasis Fertility. And we have Dr. Pawan Bendale, who is very dear friend and fertility specialist from Nova IVF Pune. So welcome, dear all. There are no secrets to success. It's the result of preparation, hard work, and learning from our failure. If I had 6 hours to chop down a tree, I would spend the first 4 hours sharpening the axe. And I believe all of us are here to learn and gain more before we go and practice fertility in our patients. So, first case coming up for all of you is Anuja, 36 years old, married to Bhushan. Known case of PCOS with irregular cycles, cycle duration 60 to 90 days, and follicle number per ovary more than 20. So, PCO morphology with no evidence of clinical or biochemical hyperandrogenemia. The BMI is 28.7. There is no clinically significant past history. In the male partner, we have semen analysis showing 10 million count with 20% progressive motility, and morphology is normal. Was given multiple courses of antibiotics and antioxidants as well. These are the parameters in the female. The AMH is 7.44 to note down, and the vitamin D levels are 22. So now she had already undergone ovulation induction with timed intercourse cycle at many centers. She underwent 2 IUI cycles outside, and now she has come up to you. So she is 35 years old already. In PCO patient, is the time important? Because we have a good reserve, then why to worry about time? So I would ask this question to Dr. Samida probably. What is the importance of time, especially in case of PCO patient? Can we wait, or what is the effect of time on oocyte quality, oocyte number in PCO patient?
First of all, sir, PCO itself predisposes the patient to poor oocyte quality. Added upon the age on it, the quality of oocytes will go further down, even if the number of oocytes that we retrieve would be on a higher side. So these are the patients, we should not take them for granted that even if the AMH is good, even if we can see many follicles on sonography, we should keep them in the same time frame as well. We should not add to the factor, we should not let them add the age to the factor of PCOS. That will become like, plus he also has a male factor in the scenario. So we should probably push them for a better IVF treatment.
Yeah, that's a good message that we have a time which is also important, especially in PCO patient where the reserve is good. AMH levels are going to remain higher, but the oocyte quality is going to get affected. This patient later on went laparoscopic ovarian drilling and hysteroscopy. Her tubes were patent. So now, is laparoscopic ovarian drilling justified, Dr. Pawan? In this scenario where we have an option of IVF, is laparoscopic ovarian drilling justified?
Actually, it's not justified because she already had stimulation with gonadotropins, and her age is 34 years. So we should probably take her for IVF, which is better. Because in many times in patients with laparoscopic ovarian drilling, we see ovarian reserve is quite less after the procedure, if the procedure is not done properly.
Yeah. So probably a patient where we want to buy time and the patient doesn't want to go for gonadotropin IUI cycle and probably doesn't want to go for IVF cycle, previously didn't have any IUI. The message is that in those patients, we can do a laparoscopic ovarian drilling and wait for next 6 months for spontaneous conception, or maybe probably do a IUI after that, after the LOD. But in this patient where she has already undergone IUI cycles and the tubes were patent on HSG, a laparoscopic ovarian drilling may not be the justified treatment in this patient. What next can we plan, Dr. Deepshika, for this patient?
So as Dr. Power has told, IVF is the right pick for this patient. Seeing the age factor of the patient, seeing the male factor, and already she had a history of a long infertility history and long treatment history also.
Anything before IVF? Her
Life-
BMI is 28.
Lifestyle modification.
Yeah.
We will try to push her for the weight reduction, 5% to 10% weight reduction.
Now, very critical question. Her age is already 35. She has waited for long years. So, how much time to wait for weight reduction is the important question.
So, meanwhile, when we are preparing her for IVF, till that time we will convince her for the weight reduction and preparation, like antioxidant, vitamin D. Vitamin D was 22 that time. So, we will prepare her for IVF.
Yeah. So, Dr. Kanchan, what is the role of vitamin D in PCOS patient?
Basically, the PCOS patients are seen to be very, papers are there where the PCOS patients are seen to be deficient in vitamin D. So as this patient also had a low vitamin D level, so vitamin D supplementation will help in improving, I will say, insulin resistance will be somewhat improved. Egg quality, I will not say, but insulin resistance, yes, it will be improved.
Yeah. She then underwent 2 more cycles of IUI because she didn't want to go for IVF. And here she had the sperm count was 12 to 14 million and there was no success. So since Dr. Mugdha is not there, what we could have done differently for this patient? I think Dr. Deepshika has already mentioned that instead of going to IUI directly, we would have advised lifestyle modifications for this patient along with this treatment. Elderly PCOS, I think covered by Dr. Samida. What precautions you would like to take to stimulate her, Dr. Samida?
So any elderly patient, basically for any PCOS patient, first thing that comes into mind is the life-threatening condition of OHSS. So it would reflect very badly in an elderly patient as well. So first precaution that is to be taken is that we should not end up putting her into OHSS. Secondly, elderly patients we should be taking care of whether they do have any other medical disorder underlying. So physical fitness is very important. Thirdly, while they are on stimulation, any PCOS patient on stimulation does have higher level of estrogen throughout the stimulation. So it might predispose them to any thromboembolic disorder if the hydration is not good, plus if they are not ambulatory. So that counseling has to be done throughout the stimulation cycle.
Absolutely. And they are obese also. If they are obese, that also adds to the risk.
Absolutely.
So, Dr. Rashmi, would you like to add any preventive methods to prevent OHSS, and during the stimulation, what care you can take?
One of the most important thing we can do is to add metformin during the stimulation cycle. I think that,
especially in this patient,
yeah,
is justified.
Yeah. So that's one of the things. And of course, we can also try and do a chronic low dose protocol when we are using gonadotropins so that we have a more monofollicular development rather than.
No, we are talking about IVF.
Right.
So we'll not aim for monofollicular here.
Okay.
Probably the stimulation protocol needs to be tailored in such a way that the starting dose is not very high. It will depend upon the BMI age of the patient and also the ovarian flow parameters, that is a stromal vascularity, which will be important in deciding the starting dose of gonadotropins in this patient. So the course with us was that the patient was put on metformin and antioxidants with coenzyme Q pre-treatment for 6 weeks. Then the protocol which is to be followed is always an antagonist protocol where you have a liberty of using an agonist trigger and decreasing the risk of OHSS. The starting dose was very less, that is 225 units of recombinant FSH. And here we could give agonist trigger because of the antagonist protocol. 16 follicles were expected. We retrieved 18 follicles, which is fair enough, 13 mature follicles, and we could form 4 day 5 and 2 day 6 embryos. We use microfluidics as a preparatory method for sperm selection because of the abnormal sperm parameters. And after the FET cycle, this patient was put on a frozen embryo transfer cycle as we do in PCO patient, and this achieved a beta HCG levels of 549. Any role of growth hormone in PCOS patient during stimulation or pre-stimulation, Dr. Saidi?
Yes, sir. So certain studies have showed that in PCO patient there is deficiency of growth hormone, particularly because of insulin resistance and obesity in them. So when we add growth hormone to these individuals prior to starting stimulation or during, in especially in resistant PCO when they are not responding, so in that case, what growth hormone does it increases the insulin-like growth factor 1 level, and this is going to increase the responsiveness of the follicles to FSH. So growth hormone does play a role, especially in resistant PCO patients when we are not able to stimulate them using the routine gonadotrophins.
Another important thing is we need to wait patiently till the follicles respond, because sometimes usually we add in a fixed dose antagonist protocol, we add the antagonist on day 6 or day 7. But here, sometimes the follicles may fail to grow even on day 9 or day 10. So you need to wait patiently and follow a variable dose protocol for adding an antagonist. And your stimulation can take as high as 14 to 15 days also sometimes. Here the starting dose was important because if the follicular flow was less, this could have been a resistant PCO as mentioned in Dr. Sonal Madam's lecture. Any role of IVM in PCOS patient?
Yeah, actually IVF was evolved, to prevent OHSS and PCO. But nowadays, since we have the antac cycle, we can do away with that. But especially in resistant PCO patients where we are not able to grow the follicles, we can go for the IVF. Or in individuals like where we get immature follicles, in those cases we can go for SK-IVM along with the normal ICSI cycle.
Absolutely. So whenever we are suspecting OHSS and the follicles have grown too large and too many follicles have been stimulated, in these patients you can do IVM. As Dr. Saidi mentioned, if they fail to grow, even in these patients you can do an IVM or in vitro maturation of the follicles. Any particular pre-treatment or adjuvants which are needed for these resistant cases who failed to respond previously?
Yes, sir. So pre-treatment or adjuvant, specifically, we can add metformin in these individuals. Then we can add inositols also. Especially, we have the myo and the dechyroinositol. The myoinositol usually acts at the ovary level, and it increases the glucose uptake. So the oocyte quality and the retrieval of the oocyte is better, and dechyro will decrease the insulin resistance. In individuals who have elevated DHEA level, we can add in like steroids for those individuals. Then, to increase the ovarian blood flow, we can also add an aspirin. And, just for the endometrium to line up with it, we can add vaginal sildenafil also.
Yeah, thank you. Wonderful. The role of insulin sensitizers remain important whenever it comes to PCOS management, even in cases of IVF. Any other investigations which we can plan, which should have done in these patients, Dr. Pawan?
We can do like lipid profile because these patients are at higher risk for cardiovascular.
So she is elderly, obese, and PCO. Puts her in a very, very high risk condition, as somebody mentioned, Dr. Samida mentioned about taking proper care to prevent thromboembolism is very important in such category of patients. So even if you can think of adding a low molecular weight heparin if she had a history of any thrombosis or if she's at a high risk. Care during stimulation and OHSS we have already discussed. We'll go on to the summary. So elderly PCOS patient, treat with care with little more caution. Protocols need to be individualized. OHSS free clinic is the dictum nowadays. So you prevent OHSS. Even if OHSS, there is likely occurrence of OHSS, you can use coasting or you can freeze all embryos. You can give an agonist trigger so that the severity of OHSS is less. With agonist trigger, the duration of action of agonist is going to be less, and therefore you don't have OHSS to that extent. Male parameters also needs to be monitored whenever we are managing any patient, and therefore in these patients where it was oligoasthenospermia, that has also been managed, and therefore the result was positive. Second case, a 39 years old lady with a husband 41 years old, hypothyroidism, and she had undergone ectopics, two ectopics, both in natural cycle, and she went bilateral salpingectomy subsequently in the two. So after that, she underwent 4 IVF cycles and 8 transfers in total. So she conceived in the second transfer, but had DADC twins, which had a missed abortion at 8 weeks. Another was a twins which aborted at 5th month after conceiving in the 5th transfer. So she didn't have any fluid in cavity right now, and AMH levels are 1.3. Again, another important factor is that reserve is low. Her AFCs are also low, it is 4 and 3 in each ovary. Husband semen parameters also show severe oats. So, sounds, can we have the diagnosis here? complete diagnosis of this patient?
Recurrent implantation failure.
Yeah. So this is a recurrent implantation failure. What is the difference between recurrent implantation failure and recurrent IVF failures?
So both are same.
Samida? A subtle difference.
IVF failure could be like not forming the embryos itself. That
Yeah.
could be IVF failure.
Yeah.
And implantation failure is when we have transferred already 4 or more embryos, good quality embryos, and she is still failed to.
Yeah. So subtle difference where we have already transferred good embryos and no success gives the implantation failure. And IVF failures can be failure to stimulate or poor egg quality and poor sperm quality, or therefore resultant poor embryo quality. So any evaluation we would like to do on male side for repeated IVF failures?
So karyotyping and DNA fragmentation index.
Yeah. So karyotyping for severe roads less than 5 million count, you need to evaluate the husband. Doing the karyotyping, you can detect translocations, inversions, any problems like this in the chromosomes. Y chromosome microdeletion again is very important test. And along with that, sperm DNA fragmentation is important. All this can change your management finally. If there are karyotyping abnormalities, you may have to do a PGT for such patients. So how to evaluate RIF in total, Dr. Saili? What all can be the causes of recurrent implantation failure?
So when it comes to RIF, first we need a proper 3D sonography and a hysteroscopy to rule out the anatomical causes. So the main causes, when it comes to the cavity, it can be because of thin endometrium, it can be because of an intracavitary fibroid or any polyp or any, congenital anomalies in the uterus. We also have to rule out hydrosalpinx or any such things. We need to evaluate the endometrium, the 3D cavity evaluation, and to check how the thickness of the endometrium and the vascularity is going. Then coming to the immunological causes, if it's a recurrent implantation failure, we can go for certain factors like the natural killer cell activity, the interferon gamma. All these factors can be evaluated. Then when it comes to the male patient, we should go for the karyotype of these individuals and a sperm BFI. And in terms of female, the recurrent implantation failure can also be because of the changes in the receptivity. So we should go for the ERA testing in these individuals also.
So in a nutshell, when it comes to IVF failure, we need to understand the seed, soil, and the environment here. So all three factors are important. The seed, that is the embryo, is important. The soil, the endometrium, is important, and the environment, that is the uterine environment and the environment around the uterus. All three parameters are important. Egg and embryo quality depends upon the oocyte and sperm quality. This will affect. So that you have to assess and you can treat there. Endometrial receptivity or thin endometrium, that's the endometrial cause. And as Dr. Saili described, all other causes of RIF. And these are the diagnostic tools which we have already mentioned by Dr. Saili. So next question to Dr. Deepshikha, should we put cervical stitch for every IVF conceived twins? Because this patient had an abortion at 5th month.
So it is a controversial question, but in practice, I do that.
I would like another comment from any of the other panelists.
Actually, theoretically it is not, but we are patient has already had failures, and if she is actually we should if the 5-month failure is there, then we should go for single embryo transfer.
Absolutely.
Yeah, so single embryo transfer will be better for her. 5th month abortion is there, but yes, in practice actually we go for this. Yeah.
Yeah, I leave it to the audience to decide. So this patient was evaluated for RIF and we could see the protein S was decreased and beta-2 glycoprotein was positive. So these parameters also need to be assessed with thrombophilias. And later on, this patient, we also considered the pre-treatment to be given. So any pre-treatment to be given for RIF patients, would that help? For poor ovarian reserve, Dr. Kanchan, any pre-treatment which would help in optimizing our IVF success?
Pre-treatment in the form of estrogen when we are planning the stimulation of the
Pre-treatment and adjuvants.
Yeah, adjuvant in the form of again DHEA. DHEA has been proven to improve the egg quality. Again, CoQ10. Dose should be proper at least 200 mg to 200 to 300 mg. 100 mg will not do. 200 to 300 mg, that is BD dose should be given at least. So we should know the preparation that we are having, what dose it is having, and then accordingly we should titrate our dose. And then pre-treatment in the form of estrogen, growth hormone not proven role, but yes, some practitioners give. Again, DHEA has a proven role.
Yeah. So we have to remember that there are many molecules which are available as adjuvant treatments and antioxidant treatments which will help to optimize and improve the egg quality, especially in poor ovarian reserve patients. And coenzyme Q10, growth hormone are some which are justified. We are justified in using those. Testosterone gels pre-treatment for around 2 to 3 months can optimize results in your POR patients. So DHEA, CoQ, and growth hormone have shown better clinical outcomes in terms of achieving a pregnancy and lowered gonadotropin dose which is required. And mind you, this has to be given for 2 to 3 months before you go for the next IVF or stimulation. Even for that matter, treating a male partner, oligoasteroteratospermia, is that important? What do we do before we go on to the treatment for IVF in the next cycle for male subfertility?
So I will tell what I do in my practice. I always tell the husband that semen analysis does not tell you about only sperm. It tells about your overall health. So first thing is the lifestyle modification. The good sleep for 8 hours, then a plate full of Bibgyor, that is all colorful food that will contain the natural antioxidants. Exercise, frequent ejaculations, like frequent coital frequencies, then the role of antioxidant for 3-1, vitamin D, and if there is any added medical disorder like hyperprolactinemia or hypothyroid, we need to correct that. And in cases, we can give the clomiphene citrate and gonadotropin also. That depends on the FSH and testosterone.
Which patients will give clomiphene citrate and gonadotropin, Dr. Kanchan? For say oats, do we give empirical CC or is there any evidence base for that?
Yes, empirical CC is not recommended basically. So we need to look at the testosterone by estrogen ratio.
Yeah.
And also the FSH level and testosterone estrogen ratio. And if it is raised, then we should go for CC or letrozole. But letrozole again the cost will
So whenever the testosterone levels are low, normally they are more than 280, then in these patients we can use clomiphene citrate 25 milligram once a day for around 2 to 3 months, with or without using HCG for these patients. So this can be helpful. Gonadotropins or HMG can be used for hypo patients. HCG can solve the matter in these patients where there is a male subfertility with problem with the testosterone estrogen ratio. So these are the pathological effects of reactive oxygen species on sperm function, not going into the details. So this is what we want to prevent whenever we are going for the next cycle. Don't be in a haste to put the patient in the next cycle because patient had already undergone 4 IVF failures. So understand what the pain they are going through. Take efforts on them to improve their semen, sperm parameters and egg parameters and then go ahead. Is there a role of hysteroscopy before we go ahead and transfer in this patient, Dr. Samida? What is the role of hysteroscopy?
We have already seen in the morning sessions the role of hysteroscopy in cases of recurrent implantation failure. So hysteroscopy reveals a lot many hidden stories like micropolyps, some flimsy adhesions could be there. At times, some signs of infection, chronic endometritis could be there. That could be dealt a cycle prior to the embryo transfer. So definitely there is a role of hysteroscopy in the same setting. PRP can also be instilled in this kind of cases.
Do you recommend hysteroscopy before each IVF?
No.
Then when do we recommend?
At least after one IVF failure cycles prior to next frozen embryo transfer cycle.
I think this is the message which you should take, that routine pre-IVF hysteroscopy is not recommended. But once you have a failure, you need to do a hysteroscopy because you may diagnose certain conditions which can be diagnosed only on hysteroscopy. So what protocol you would like to use in poor responder patients? I would like to ask Dr. Saili and probably Dr. Samida to share her experience. Yeah, Dr. Saili.
Okay. So in patients of poor responders, we want to get the maximum yield of the oocytes and the quality also. Now, in these individuals, they usually can have a premature LH surge and hyperactivity of the FSH. So we can go for a long agonist protocol in these cases, or we can give a down regulation with OC pills for like 14 to 21 days and go for a microdose flare protocol. So when microdose flare, when it is given in microdoses, that will just cause enough stimulation. And along with the gonadotropin, these protocols can give better results.
Your experience, Dr. Samida?
This kind of patients can also be put on dual stim or Shanghai protocols. as well, because the conventional follicular phase stimulation followed by a gap of 3 to 4 days followed by luteal phase stimulation, and studies have shown that luteal phase embryos are also good enough. So it's like an embryo cooling cycle and they can give you a better result.
So individualizing protocol is very, very important. You have to assess all the patient parameters. You have to study which protocols were used for the previous 5 year cycles. What was their outcome, like number of oocytes, number of mature oocytes, number of blast form, and accordingly you choose the protocol for that patient in the later cycles. If we compare antagonist and log agonist protocols which are conventionally used, there is no much of a difference or they are comparable when it comes to pregnancy rates. When we see long agonist protocols, or for that matter, what Dr. Saidi mentioned, microdose flare protocols, these are the patients where we get little bit more number of oocytes, and therefore maybe we can expect a little bit more blast conversion. So this can help if the patient had previously been undertaken with the antagonist protocol. So these patients, in this patient, we did IVF and we did a pre-implantation genetic testing to decrease the time to pregnancy. Also did an ERA for this patient, and finally the ERA was shown to be receptive at 123 hours, and the patient went home with the baby. So for these patients of RIF, I would like to ask Dr. Rashmi, what are the options, advanced options, like we discussed ERA and PGTA here, we have been discussing that.
Yeah.
What are all the options, plethora of options available?
So on the male side, we spoke about using DNA fragmentation index and then SOS TISA, if at all. On the female side, there's a role for immunotherapy like IVIG, peripheral blood mononuclear cells, intralipids. Although all these things are in trials right now. And of course, there's a role for ERA for the window of implantation, and PGTA can be used selectively.
Right. So these are the options which we have available with us, and we can use selectively. Not all options will be there for all patients. We have to be absolutely selective when we choose all this. So this is the SOP and the standard algorithm which I have formed for RI. Go for all three things. One is seed, one is soil, and the environment. So look at the oocyte and sperm factors, try to improve them, use good adjuvants, use a good protocol for stimulation so that you get good oocytes. Sperm selection techniques can be used if some sperm parameters are abnormal, like you can go for TISA if it's severe odds less than 1 million, so you to get a good sperm quality, or you can use non-invasive techniques such as magnetic assorted cell sorting or microfluidics. For endometrium, you can have thin endometrium. You can improve the endometrium by different techniques such as hysteroscopy, subendometrial PRP injections, GCSF, and so on. Even for that matter, stem cells. Endometrial receptivity and finding out the personalized window of implantation also remains a good option. And other things are like for genetic, we find the cause, you to go for PGTA. Anatomical cause, we correct it. Pelvic and pelvic causes, we correct it by doing a laparoscopy if there are any. Endocrine causes can be corrected. Infections like chronic endometritis needs to be treated by a prolonged antibiotic dose, and this can be diagnosed by a CD138 molecule immunohistochemistry of the endometrium, or by doing the hysteroscopy where you get a triad of micropolyps, stromal edema, and strawberry appearance of the endometrium. And immunological causes, what Dr. Rashmi mentioned, have an array of treatments which are available in the form of intralipids, IVIG. Although all are not substantiated, you can be very selective using this immunotherapy methods. You can measure the uterine action killer cells. You can measure the TNF alpha levels. If these are raised, you need a definite treatment for immunological treatment for these patients. If these are not raised, probably you can use an empirical treatment which is relatively safe. You find it for yourself and use. Last case, male subfertility. We'll quickly go about treatment of azoospermia. Dr. Pawan, how do we diagnose azoospermia, and like how many times we repeat the semen analysis, and how do you confirm the diagnosis?
If there is a absence of sperm in the semen sample, then we repeat we repeat after 4 to 6 weeks, and in second test also, if there is no sperm, then we will label it as azoospermia.
And we centrifuge the sample. We centrifuge the sample, yes, so that we rule out cryptozoospermia. Dr. Kanchan, how will you proceed with the case of azoospermia? What all investigations you will do, and how will you come to a diagnosis about the cause of azoospermia?
So first and foremost is the basic evaluation. hormone testing in the form of FSH level, testosterone level, prolactin should be done, baseline thyroid should be done. Then USG scrotum and genetic cause, if any. So karyotyping, Y chromosome microdeletion, that needs to be done. So basic these investigations can let us know if the FSH levels are raised. Then we can think of whether it is the testicular cause, the FSH levels are raised. So the testicular cause of azoospermia, or if the most commonly it is a obstructive, where we will get 60% it is a obstructive, where we will get all the hormone levels will be normal, FSH will be normal, testosterone will be normal. So these patients again have a good sperm retrieval at TISA. Then hypo again, it will have low sperm, low FSH and low testosterone. Again, in these patients, sperm retrieval in the operative will be guarded.
Yeah. So, what is the because this case is of obstructive azoospermia, I would like to ask for hypo patients, what is the plan of treatment? If we see that the FSH and LH levels are less than 1.5.
For any case of, I would like to summarize what Dr. Kanchan has said. For any case of azoospermia, the first and the foremost thing is we have to diagnose whether it is obstructive azoospermia or non-obstructive azoospermia. Secondly, we need to do karyotyping and Y chromosome microdeletions for all of these patients. If the karyotype is normal, then we can think of going ahead with medical management. After seeing the FSH, testosterone, and estradiol levels of this patient, if FSH and testosterone is on a lower side, then these patients come into hypo kind of category, which responds the best to the medical management. So these are the candidates for HCG 2500 or 5000 international unit, depending upon their BMI, twice a week for 3 to 6 months. Then the hormone profile should be repeated. If there is any improvement, then they should be put on HMG at least 150 international unit for remaining 3 to 6 months. So these are the patients who give the best, respond the best to the medical management.
So the message is clear for only these patients we use gonadotropins. It will be HMG, HMG or pure FSH, anyone can be used, and we can give 150 units at least twice a week along with HCG. It can be 5,000 units once in a week. And this treatment, as Dr. Samida, after 3 to 6 months, you assess the response. But tell the patient that this treatment is not going to be sufficient in 3 to 6 months. The sperm production is not going to happen immediately. The patient may require a treatment of 1 year to 1.5 years before he actually responds. So some patients do respond quite nicely and they can have natural conception after these hormonal injections, but some may require advanced ART treatments as well because the response is not that good. So this patient underwent hormonal evaluations, the FSH levels were normal, and the scrotal Doppler showed grade 2 varicocele. Patient was motivated to undergo varicocelectomy, and then we hope to improve the sperm count. Patient came back after 2 years, and it was azoospermia again with a slightly higher FSH levels now. So how should we counsel such patients who fall in between category of obstructive and non-obstructive azoospermia? Sometimes, even if we see that the FSH levels are normal, we are not able to retrieve sperms on TISA. Anybody would like to take this?
We'll go ahead with the testicular biopsy, sir.
Yeah.
And after that, IVF.
Yeah, but how do we counsel this patient? Because counseling is very important. We are in a hope that there will be sperm retrieval after
Right.
testicular biopsy.
Right.
So what's the counseling? How does the sequence of counseling goes? Anyone?
This patient should be counseled that we can take the testicular biopsy, but we might not retrieve the sperms at all. So, in case the patient has given consent for donor sperms, then and only then we can do the biopsy. And the biopsy also needs to be with the facility of cryopreservation of sperms. That if at all we retrieve the sperms, should be cryopreserved. So,
any role of microsurgical test? Anybody would like to speak about that?
Yes, sir. So if the hormone levels are elevated, then TISA might not, we might not be able to retrieve sperms. So by doing a micro testis, since we are actually opening the testes and looking for those areas of spermatogenesis, there can be possibility of retrieval of sperm. And if, we have to counsel the patient likewise that if you're not able to retrieve the sperm by microtest, then he might need to go for donor sperms then.
Absolutely. Any role of testosterone injections in such patients, Dr. Samita?
Not at all.
Anybody using? I think that testosterone tablet or injectable form should be discouraged in patients of azoospermia. Rather than helping them, they're not going to cause much help, but rather increase your problems. Everybody has talked about karyotyping and Y chromosome microdeletions. So, role of karyotyping and microdeletions in which category of patients it's more important?
So especially in individuals which have severe form of OATS or azoospermia. So in these individuals, we need to actually know what is the reason behind it. So
Especially in cases of non-obstructive azoospermia, where the
yeah, when the
testicular cause.
hormonal assessment is normal in these individuals. So in this case, karyotype, the most common genetic abnormality will be a Klinefelter syndrome, or we will be able to know about all the structural rearrangement, any micro deletions and all. Coming to Y chromosome microdeletion, Y chromosome microdeletion, when we do, it basically is an AZF-A, B, and C region. So as in AZF-A, they will have, Sertoli only syndrome, and B, we have spermatogenesis arrest. So in these two cases, the sperm retrieval is very low. There are very few chances. In AZF-C, they will be able to retrieve sperms with TISA or microtessi. But these patients should be counseled that there is a risk of transmission of this abnormality to the male offspring. Likewise.
So, are you in favor of doing a trial TISA or you do simultaneous IVF and TISA, like fresh TISA?
So mostly simultaneous IVF and TISA. We can give them option of a microtessi also likewise.
So suppose only 2 and 3 sperms are retrieved. Is there any advanced sperm freezing technology which is available?
So we can use sperm vitrification device.
Yeah.
In which we can preserve very few sperms. Like even if 1 or 2 sperms are there, we can preserve.
So there is sperm VD devices or sperm vitrification devices available here. So where you can freeze a single or 2 sperms or 3 sperms also and retrieve them equally good. So not normal sperm freezing may not be able to retrieve that low number of sperms. Dr. Rashmi, what consents are needed to be taken in advance, and if no sperms are found, what all options we have? I think everybody has spoken about it, but you can just revise.
So when it comes to consent, if we are taking up the patient for TESE, we in advance only take the consent for micro TESE. In the same setting, we can do, if TESE we are not finding any sperms, we can go for micro TESE. And then of course, if we don't find any sperms, we have already taken the consent for using donor sperms as well.
Yeah. So even if there is a azoospermia, the message is that the couple can have their own genetic child by using advanced fertility options. May it be medicines in hypo cases, may it be simple testicular sperm retrievals by using TISA in obstructive azoospermia. If it is a non-obstructive azoospermia, we can use microsurgical TESE and retrieve sperms. Mind you, karyotyping and Y chromosome microdeletions form an important aspect about treating these patients. If you have Klinefelters or any other chromosomal abnormalities such as translocation inversions, your IVF success rates are going to be low. And in these patients, especially where translocations are there, inversions are there, you can give an option of pre-implantation genetic testing of embryos of these patients and then transferring them back to have less time to pregnancy for these patients to conceive. So, azoospermia, always confirm them before revealing the report because this can be traumatic to the patient. If there is a varicocele, not always surgery can be an option. Assess the gradient of varicocele and then only decide about the treatment. Trial TISA with semen freezing can be used. TISA along with IVFs can be used. And there is no role of testicular biopsy for diagnosing. So whenever you are doing a testicular biopsy, mind you that you should have freezing, semen freezing facilities available. Because if you're doing a testicular biopsy, you're causing fibrosis and damaging the testicular tissue. So once done, the freezing should be option which should be immediately available. Thank you. In the end, I would like to have a rapid fire on Kahoot. Already you have Kahoot. So last 2 minutes. And I thank all my panelists, thank all the audience to be patient till now. We have been with a delay of half an hour, but everybody has been patient and we have audience wonderfully there. So we have the next quiz and here we won't have 3 winners, we'll have only 1 winner. So play nicely and quickly. So download Kahoot app or play on www.kahoot.it. Simple 8 to 9 questions regarding whatever we have discussed till now: PCOS, poor reserve, and male infertility. Log in with the game pin 4736372. I'll be waiting for 2 minutes. So everybody has got a chance to win a prize now. So 1 minute and we'll be starting. Anybody wants me to wait? It's done. Okay. So we'll go on to start the quiz. They don't know the quiz answers of quiz. They'll not be given the prize. Don't worry. Next. Next. We start. Yeah. The successful follicle, which is one that has all of the following parameters except: is it A, highest level of aromatase activity, highest level of LH receptors, lowest inhibin production, or highest estrogen production? All of the following except. The successful follicle has all of these except what? So you should know all the hormones, and it is lowest inhibin. Inhibin is also higher. And we have Dr. Monica who is leading, Dr. Samia who is second. So next question, please. Fast. We'll go a little rapid fire. What is the most appropriate test to detect hyperandrogenism in PCOS? All these tests can be used, but you have to look the values. DHEA more than 3,400, fasting insulin more than 20, androstenedione levels more than 2.7, or free androgen index more than 8.5. Which is the best test and correct test which is mentioned here to measure hyperandrogenism in PCOS? It is free androgen index more than 8.5. What is true about inositol according to the 2018 PCOS guidelines? It is considered experimental therapy right now? My chiro to D chiro ratio should be 40:1. The ratio should be 4:1, or inositol should be used only with metformin. What is the correct statement according to the recent guidelines? Many of us have mentioned this. And the correct answer is considered as an experimental therapy as of now. So, the gene responsible for premature ovarian failure is which gene? Is it A, CFTR, FMR1, CYP1, or CYP17? So, premature ovarian failure is ovarian failure less than 30 years of age, and which is the gene responsible for it? It's FMR1. So we have Dr. Rashmi, Dr. Rajendra leading. The dual stream protocol makes use of which of these theories? A, high endogenous FSH and LH. B, multiple follicular waves. C, high exogenous FSH. And D, longer half-life of HCG. What is the theory of using a dual stream protocol? So this protocol can be used in poor responders to improve the success, that is a luteal phase stimulation. Many of you have answered it correctly. It is multiple follicular waves. The best pump selection technique for IUI in case of res DFI. Remember, it is res DFI and you are using for IUI. So the sample should be, volume should be good. So is it A, MAX, that is magnetic cell sorting, microfluidics, density gradient centrifugation, or PIXI? Which is the most important technique for res DFI in IUI? The message is that only this technique can be used, that is max can be used for IUI if it is a raised EFL. The minimum motile sperm required for carrying out max, that is magnetic cell sorting, is how much? It should be 5 into 10 raised to 6, that is 5 million, 10 million, 2 into 10 raised to 6, or 1 million, 1 into 10 raised to 6. So it is 5 million. And this is the scoreboard, which according to the Cochrane shows a significant success rate. When we are using sperm selection techniques, according to Cochrane, which technique has shown the maximum success rate? Is it A, max, microfluidics, hyaluronic acid, or zeta potential? This is a tricky question. Slight increase in clinical pregnancy and live birth rates were observed whenever this technique was used, that is zeta potential, and you very less have answered it correctly.
About this anywhere in the conference, and you said the case will be according to what you have said.
So this was tricky question. That's what I mentioned. So we have the winner, which is I think Rashmi, but since it was organized and objection was raised, which I accept, I give it to Dr. Sabida. You have already won the first quiz. Thank you for that. I just call Dr. Kanchan for the valedictory and Thanksgiving, and we felicitate our winners here. Thank you. Thanks for the wonderful panel. Thank you.
On behalf of all panelists, sir, thank you so much for such a meticulous preparation of the panel and the quiz itself. Thank you so much.
Thank you. Thank you all, audience.
Okay, Randeep Singh. So, good afternoon, everyone. Sarvepi sukhina santu, sarve santu niramaya, sarve bhadrani paschantu, ma kaschid dukhat. I welcome dear all for the valedictory of today's fantabulous conference, ART Conclave 2022. Myself, Dr. Kanchan Durkar. I am consultant at OSH Fertility, Vakar, Pune. Today, I am here for the Thanksgiving. I thank Dr. Parag Binewale sir, our president POGS, who gave precious time and guided us for the today's conference. I thank Dr. Durga Rao ma'am. She is a medical director and co-founder at OSS Fertility. She came all the way from Hyderabad and she guided us with her valuable knowledge on infertility. And we are going home with more knowledge on unexplained infertility with her talk. And yes, Madam guided us in the workshop on OM pickup also today morning. I thank Dr. Sonal Panchal ma'am. She is a consultant radiologist at Nagori Institute and IVF Center, Ahmedabad. We were grateful to learn from her basics to advance about USG in infertility. I thank Dr. Krishna Chaitanya sir, scientific head at OSS Fertility, for guiding us on the emerging lab techniques in the modern ART practice. I thank Dr. Nilesh Balkavade sir, who is a clinical head at OSS Fertility, for conceptualizing and crafting such a wonderful academic extravaganza for all the practitioners, so that we are going up with the updated knowledge regarding ART. I thank all the delegates who came here, all the chairpersons, Dr. Vaishali Chauhan ma'am, Dr. Rajeshwari Pawar madam, Dr. Madhuri Laha, Dr. Archana Kankal madam, who came here and gave us a precious time for this conference. I thank all the delegates, all the doctors, embryologists who came here and had a wonderful learning experience. I thank all my team members, Dr. Saili, Rashmi, Bharti, Sakshi, Apurva, Govind, and all the team members of OSS who had taken a tireless efforts to make this conference a grand success. So I thank all of you for attending this conference. Thank you very much. Yes, and yes, quiz winners, Dr. Rajendra Shitoy for the quiz. I asked Dr. Nilesh Balkawade sir to felicitate Dr. Rajendra Shitoy. Uh, I asked Dr. Samida Ravi to come up on stage for the winner of the quiz. Second quiz. Okay. Dr. Pradnya, she is also a winner of the quiz. First quiz.
And Dr. Kanchan for the first quiz.
Dr. Samida for the second quiz winner. And e-poster winner is remaining. Yes. Rashmi. Doctor, yes. The e-poster winner is Dr. Randeep Singh. Is he here? Yeah, please come. Sir, can you, yeah, paper presentation, his paper. Sir, please. His paper presentation, just his paper.
So the winner is Dr. Randeep Singh for his poster on empty follicular syndrome.
All the delegates are requested to collect their certificates from the reception desk. Please fill the feedback form and collect your certificates. Workshop certificates and conference certificates are there at reception desk. Yes, yes. Thank you one and all. Thank you very much.
Right.